Good morning and welcome to colleagues from around the world. This is our uh, third and the final day of live surgical event. We started on Monday with Prof. Paulo Castanova and with Prof. Manuel Bernal Speckelson from Spain. And then we joined Columbus, Ohio. And yesterday we also had great surgeries from the centers with Professor Richard Harvey in Sydney, Australia. And today we're looking forward to this grand finale. So we have very interesting cases lined up. We have with us Dr. Satish Jain from Jaipur, India. He hardly needs any introduction. He has been a very integral part of GRN events, live surgeries, and they have always been very, very popular. So we have some very complex sinus surgical cases lined up, almost testing the limits of sinus surgery, so as to say. So interesting day lies ahead. I have with me my colleague Louise Melia. So good morning, Louise, and
good morning, Ashok.
So Louise is from Bath in the UK. She's a rhinologist and a skull-base surgeon. So we will go over to Jaipur to join Dr. Jain.
Thank you, Dr. Rukade, for this opportunity once again. And I welcome you all to this telecast from the pink city of Jaipur. I remember, and I'm so grateful to Dr. Rukade for involving me in his academic programs, which are very popular to spread academics all over, particularly in the Western world. I have some fond memories of the previous telecast, wherein we had a lot of interaction during live surgical session. So once again, thank you very much for giving me this opportunity and involving me here. Today, we have lined up a variety of endoscopic cases. We will, of course, begin with a young child having JNA, extensive JNA with all possible extensions, and we'll go endoscopic with discussion on indications and all those things. Then we have some endoscopic interesting cases like adenoidectomy with cobblator and microdebrider. We have some primary sinus surgery. We have some focus on frontal sinus surgery. Then we have cases of revision sinus surgery, and then interesting CSF rhinorrhea with meningoencephalocele. So probably we'll go till 3 p.m. India time, or maybe beyond, depending upon the, what Dr. Rukade directs me. So today I am all over to him for his, this academic event. And thank you once again.
So in aviation, the hierarchy is aviate, navigate, communicate. So first of all, you have to fly the aircraft. Only when you've got that safely done, safely achieved, you can start to navigate. And only when the navigation's taken care of do you then communicate with air traffic control. So to an extent, if you're flying, you're either navigating or you're lost. So what are the threats from being lost? Well, you might have to land at the wrong airfield or run out of fuel before you can find somewhere to land. You might infringe airspace, possibly causing a diplomatic incident. You might infringe what we call a NOTAM, which is a notice to airmen, which could be, in the UK, it could be a member of the royal family flying from A to B in a helicopter. All of these things will get you into varying degrees of trouble. And that's what we're trying to avoid. So there are several layers, if you will, of navigation. The first one, if I'm flying along, let's say I'm very familiar with my local airfield and I'm just going out for a Sunday jaunt, then I'll just be navigating visually. And I'll know all the features around that airfield, and that should be a pretty easy task. If I'm then going further afield, then I might start to use a map and stopwatch. So on my map, which has got all the airspace on it and lots of features that I can see visually, I'll draw a straight line with a ruler and I'll work out how long that leg of navigation is and what heading I need to be on to fly that leg accurately. So we've gone from visual navigation to then map and stopwatch navigation. And after that, if I've got systems in my aircraft, I can start to use those. So as a fighter pilot in our aircraft, we had inertial navigation systems. So a bunch of accelerometers and G meters, and they work out the change from one moment to the next. And they're very resilient to maneuver, which is good if you're in a fighter aircraft. So the airplane knows where I am in one moment, and then it looks at how much acceleration I've put it under, and therefore it knows where it is subsequently. But over time, those systems drift. So over about an hour, I might lose about a mile of accuracy with that system. So every once in a while, they need updating, either by flying over a feature on the ground, or by GPS, or by radio beacons. So we had visual, we had map and stopwatch, and that was talking about my inertial system in my aircraft. And then if I'm flying along in cloud, if I'm an airline pilot, I've got inertial systems, but I'm also using radio beacons to navigate with. And they're pretty accurate. And generally airliners fly for, certainly they used to, less so these days, they used to fly from one radio beacon to another. And that's navigation in a nutshell, really. And these days, a lot of those systems are combined. So as I hinted at, the inertial navigation system will be updated by something like GPS. And GPS is very accurate, but it's not very resilient to maneuver. So combining those two, where you've got the inertial system, which puts up with the maneuvering, and you've got the GPS, which is very accurate over time, gives you a really robust system. So hopefully not too technical there, but the aim was to provide an overview of the various navigation systems.
Well, it's interesting. I sort of started training when navigation was being introduced and more accepted as routine, but we didn't use it in every case. It was considered quite fancy and high tech. And really what we've always used is key landmarks as a way to know where you are. So before you even consider operating, you'll do some form of scan, usually a CT scan. And a CT gives you better landmarks from bony anatomy, which is more reliable in surgery, because soft tissue anatomy can change. You can have swelling and shrinkage and polyps and infections and things, but the bony anatomy doesn't tend to change over time unless there's tumours, etc. So we usually have a CT scan, and before you operate, you'll go over that scan and identify those key landmarks, but also identify unusual anatomy or some changes in the anatomy that are unique to that patient. There's some key things we want to know. Where are the blood vessels that supply the eye that can hang down in the nasal cavity, so we don't injure those, because that can cause blindness if not addressed. We also want to know where the base of the skull is, so we don't breach that if we're not intending to. We want to know where the eyes are and what the shape of that patient's orbits is, if they're a bit square or rounded, so we don't penetrate into their eye or injure any of their eye muscles. We also want to know where their optic nerve is, among other things, as well as their carotid arteries. So there's a few key things we look at as a routine, and we have a mnemonic called CLOSE, C-L-O-S-E, which looks at those key anatomic features in every patient, because they're unique in every patient. And then when you've looked at that, you've obviously examined the patient looking for other things like septal deviations or turbinates or big polyps. What we then rely on is, with the endoscope, we're relying on that anatomy. And as we proceed through the surgery, we're sort of ticking off those things in your head. Okay, I've identified that artery and I've left that alone. I've now worked out where the orbit is and I've cleaned that off. I've left that alone. I've now moved through to this particular sinus where I can now find the skull base or the optic nerve, etc. So really what we used before was anatomic landmarks and scans. Now, in dire situations where you really weren't sure, I have known of people to leave a metallic object somewhere, a CT or an X-ray, to confirm that that's where they thought they were, but that's pretty unusual. So we don't have as many fail-safes as they do in aviation. We really rely on anatomic knowledge and anatomic features as landmarks if we don't have navigation.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates, and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there, and we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis, because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use that a lot. And these are the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, especially in patients with severe polyps and samtostroid. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.
Can we go ahead with the CT pictures or the imaging?
Yeah, please do.
So, Dr. Rukade, I would love to be interrupted again and again for any questions from the audience to make it more and more interactive. Believe me, this is again a good learning opportunity for me as well with this interaction. So, I welcome Dr. Lewis for this wonderful day for the interaction, and I'm very sure that will be definitely everybody will be benefited with this kind of interaction. So, this first case, as I discussed, as I told you, is a young child, is a 12-year-old child with a nasal blockage. On endoscopy is a mass in the nasal cavity and nasopharynx. And then, in a 12-year-old child with such kind of a mass lesion with history of, repeated bleeding is always something which goes in favor of JNA until proved otherwise. Now, JNA being a vascular tumor, it has a propensity to bleed, we all know. So we never, advise biopsy for such lesions to prevent hemorrhage. So our diagnosis is further established by imaging. Now, there are lots of controversies regarding what kind of imaging to be ordered. So here we have an imaging protocol with discussion on pros and cons of kinds of imaging. So the first imaging what I'm showing is a non-contrast CT scan. Are you getting CT on the screen?
Yes, we are.
Yeah, so this is a non-contrast CT scan. See this in the DICOM format. If I show the coronal one, what you get on this non-contrast CT scan, is a mass lesion in the nasal cavity going, see this broadening the sphenopalatine foramen going out, but you cannot differentiate what kind of lesion it could be. There are variety of nasal masses from benign to malignant, n number of nasal masses could be, and a non-contrast CT scan cannot actually differentiate between, what kind of a mass lesion it is. So we need a contrast CT scan then. So then let me show you a contrast CT scan. Contrast will give you enhancement. And rather than a plain contrast CT scan, we advise this CT angiogram, which is actually a contrast CT scan with a dedicated angiographic pictures to show you more, to give you more information than a contrast CT scan. So our primary investigation to order when we suspect JNA is a CT angiogram. This gives you enhancement and more information. Let me show you in all three planes what the CT angiogram shows. So in this picture, if you look at the coronal picture, see this. This is the coronal one. If you look at this, see what kind of information it is giving you. This is a enhancing mass lesion which looks like centered at the level of the sphenopalatine foramen and going either side. It is, spreading circumferentially. It is going medial into the nasal cavity, and if you go behind in the nasopharynx, then it has eroded the pterygoid process, then it has eroded the sphenoid floor and, bulging in the sphenoid. It has prolapsed outside through the sphenopalatine foramen, pterygomaxillary fissure into the infratemporal fossa. See, it is going in the infratemporal fossa both inferiorly and superiorly. The most superior part of the infratemporal fossa is involved. Then it is going up. See, this is the greater wing of the sphenoid. This is the greater wing of the sphenoid on either side. And what it is showing, it is eroding the greater wing of the sphenoid and rising up in the temporal lobe of the brain, though being extradural. Wow. See this? And if I show you the sagittal one, you will see better that how it is rising up and going behind and beyond. See this? This is the mass lesion. This is going, see, this is the orbit. This is entering into the inferior orbital fissure. Can you see very clear?
Yes. Yeah.
Yes.
Going behind through the superior orbital fissure and then going behind in the cavernous sinus, in the temporal lobe of the brain. It is rising lateral to the cavernous sinus into the temporal lobe of the brain. Now, let me show you on the axial. So, all three planes gives all valuable information. See this, this is the mass lesion. Can you see very clear now?
Yes, yeah.
On the axial.
Very extensive.
CT, a contrast CT scan gives you all classical extensions of JNA, and because of these peculiar extensions, the JNA is diagnosed on the basis of radiology rather than on biopsy because it has some preferential extensions. Preferential extension means preferentially it goes in the nasopharynx and the nasal cavity. Preferentially it goes laterally. See, this is anterolateral extensions. Can you see?
Yes. Yes.
And this is by means of eroding the pterygoid, it is going posterolaterally as well. See, both separate extensions, classical. Then see, when you go up, it is going in the inferior orbital fissure. From where it is going behind, and behind, see, this is the foramen lacerum carotid artery. And this is through the superior orbital fissure, it has gone towards the cavernous sinus. It is bulging towards the temporal lobe of the brain. So this is classical extension. The important thing to be noted here is JNA never invades the paranasal sinuses. Of course, it bulges in the paranasal sinuses, but it never involves the mucosa. Never invade the mucosa of the paranasal sinuses. It never invades the cavernous sinus through the paranasal sinuses. We have a general feeling that after involving the sphenoid sinus, it can involve the cavernous sinus. It never goes like that. See, the sphenoid sinus is separate. Can you see the bone? Separate bone of the cavernous sphenoid sinus all around. And this is coming from the inferior orbital fissure, superior orbital fissure. Superior orbital fissure is actually an extension of the cavernous sinus anteriorly. So, it has gone from the superior orbital fissure into the cavernous sinus, bulging in the cavernous sinus, and see the carotid artery behind. So, it goes circumferentially. And see, this is the bony wall all around the carotid artery. Can you see here?
Yes.
This is the
Yes.
horizontal petrous carotid. This is the foramen lacerum carotid. There's the bony wall. Then this is the cavernous carotid. Now there is no bony wall. And this lesion is particularly, going towards the cavernous, and it can compress the carotid artery. But most of the time it doesn't actually invade. And it progresses towards the cavernous sinus and towards the, superior orbital fissure, cavernous sinus, and this temporal lobe of the brain. It is pushing but not invading the dura. So by means of all these extensions, you can have a fairly good diagnosis of JNA. Now, this being a vascular tumor, you need more information about it. That's why we order, rather than a contrast CT scan, we order a CT angiogram to give you more information about vascularity. See, when it comes to, management of JNA, the first and the most important thing which frightens surgeon is the bleeding. Vascularity is the major concern, and this CT angiogram gives you most valuable information about the vascularity. And what I believe, what I always propagate, we surgeons must know how to read out the CT angiogram to know how the vessels are related to the tumor. See, I need information how we all know the internal maxillary is the principal vessel, primary principal vessel. We should know how the internal maxillary is entering into the tumor so that we can catch it at the right place. How the other vessels are invading into the tumor and supplying, because all these are important for the decision making. If I have a, why this JNA is approached endoscopically most often? Because the internal maxillary comes anterior to the tumor. You can catch the internal maxillary prior to the tumor removal. So you can devascularize the tumor. And that is the biggest reason for the endoscopic, your ability to excise it endoscopically before, because you take the vascular control before and then remove the tumor. Now, what happens if the vessel comes from behind? If you have extensive vascularity coming from behind the tumor, to me, is the strongest contraindication for a simple endoscopic approach. Either you embolize those vessels primarily to devascularize it, or go by open approach, because otherwise, simply without embolization, you cannot, enter into the tumor, which is too vascular, without taking the vessels in control. So let me show you how to read out the CT angiogram quickly and what is happening in this particular patient. See this, I will show you from below. See, I am starting from the neck. Can you see this carotid artery in the neck?
Yes, yeah, very clearly.
Very clearly. See now, the carotid artery, jugular vein. Now the carotid artery, jugular vein. Now I am going up, up, up. See this, I am going up. And now the carotid is being divided into two. Can you see?
Yes.
Yes.
Yeah, let me show you better picture. See how the carotid being divided into two. Let me show you a better picture. See now, follow my cursor. This is the common carotid artery. Can you see this is the common carotid artery on the right side?
Yes, yeah.
Now I am going up, going up, going up, and this is being divided into two vessels. Is that clear?
Yes, yeah.
Yes.
And
You can
now
the
see there are
division.
lots of branches arising from the external carotid. We know internal carotid doesn't give rise to any branch. So now there are numerous vessels, we all know, all named vessels arising from the external carotid. Right from the first one, this is ascending pharyngeal. Then if I go further, this is thyroid, superior thyroid. Then I go further, lingual and the facial going laterally. If you follow this vessel, this going, see this, I am following this vessel going lateral to the mandible. This is facial artery going back. So further, I am going further. Now the carotid is going behind. Can you see the external carotid turning behind?
Mm-hmm.
Yes.
Yes.
The first branch, the first posterior branch it gives off is occipital. Can you see very clear?
Yes.
Going further, it gives further branch, posterior branch. This is posterior auricular artery. Then going behind the mandible, see this. This is mandible. And this is dividing into two terminal branches. Can you see very clear?
Yes. Yeah.
Yes.
The outer one is superficial temporal and this bigger one is internal maxillary. Now I am going to follow this internal maxillary. See this internal maxillary. See my cursor. Can you see this?
Mm-hmm.
Yes.
Yes.
Yeah.
Gone medial to the mandible and this vessel is going. See this. This vessel is going. This vessel. See my cursor. Where this vessel is going? Anterior to this tumor.
Anterior
This
to
is
the
all
tumor.
tumor going anterior here and here into the pterygopalatine fossa. Can you see very clear?
Yes.
Yes.
Now, to ascertain the level of this vessel, wherever this has to be caught in the pterygopalatine fossa, you have to catch at the right place. Let me show you where exactly. This is the basis of, endoscopic excision of JNA. See this vessel, it is going there, it is going in the pterygopalatine fossa. This is how this vessel goes on the normal side. This is this vessel, which is here on the disease side. This is the vessel. If I look at this vessel at the coronal picture, see this. This my vessel is here. And now I am
Yes.
going to follow.
So,
See
yeah.
this vessel is riding up,
Yes.
and this is at this level, it is entering into the pterygopalatine fossa. See this here? So, endoscopically, to catch this vessel in a bigger tumor is a very, very difficult task sometimes. How can you catch? With the CT angiogram, my vessel is here. I can use my, see this? This vessel looks like around 1.8 centimeter above the level of the floor of the maxillary sinus. 1.7 to 1.8. Can you see?
Yes.
This vessel here. So while looking at this vessel, I should have a fairly good idea where to catch this vessel and devascularize this tumor. See, in this surgery, why I am able to take this case endoscopic? From vascularity, the internal maxillary being the principal vessel. My entire goal during surgery is not to enter into the tumor at any point of time without devascularizing it. And that is how we devascularize, we find the internal maxillary at the right place before entering the tumor and catch it and devascularize the tumor to a certain extent. Rest my cobbletter will do. This is the principle of, endoscopic surgery for juvenile nasopharyngeal angiofibromas without embolization. So in our practice, 95 to 98% of the time, we have been able to remove such tumors without embolization. Embolization, of course, is a good strategy to devascularize the tumor, but it has its own pros and cons. The embolizing, intervention radiologist should be very, very expert to prevent dissemination of the agent through the dangerous connection to the internal carotid circulation. Otherwise, it can have its deleterious effects. The cost is another factor. The tumor-related factors are different. So embolization is not always always a good thing, always a welcome thing, I would say. And with this technique, which I am going to show you today, this being such an extensive tumor going intracanally, cavernous sinus, far extensive into the infratemporal fossa, even towards the parapharyngeal space, sphenoid sinus, everywhere we'll be able to remove without embolization and most of the time even without transfusion with this surgical strategy to catch the vessel first. And this CT angiogram is the principal investigation to give you adequate information about the vascularity. Number two, once you deal with the carotid artery, you should have complete information about the cross circulation at the level of the brain. Now see, these are two carotid arteries anteriorly and this is the basilar artery behind. Can you see?
Yes. Yes.
If I look at the cross circulation, see these are giving two posterior cerebral arteries. Can you see? And
Yes.
these carotids are giving two anterior cerebral, making ACOM and the A2. Very clear? This is anterior communicating artery and this is the posterior communicating artery arising from the posterior cerebral going towards the carotid to complete the circle of Willis. So
Circle of
what I
Willis.
believe, see this is a cross circulation, adequate cross circulation. To get more information, the DSA is gold standard, digital subsection angiography. But this gives you a fairly good idea that the patient has a good anterior and posterior communication good anterior posterior circulation in case of any, unfortunate situation of arterial injury. Still there is adequate circulation to sacrifice the vessel without giving intracranial complications. So DSA will definitely give more information in case your artery is at risk. It is completely encased, giving a lot of arterial disabilities, deformities. Then obviously the DSA is important. In this case, the tumor is approaching the carotid artery but not invading it. Okay. Now, this information to me is still inadequate. I need more information about the diagnosis, about the extensions, about the arterial involvement, about the vascularity from the MRI. So my first MRI would be a T2 weighted MRI, T2 weighted MRI, T2 weighted.
Dr. Satish, at this stage, is it fair to say that it is a very extensive tumor?
Yes,
it has invaded all these possible spaces.
Yes, you can see.
But at the same time, the main vascular supply, which is IMAX, is in a kind of favorable location. It is anterior to the tumor.
Yes.
Okay.
See, it is always anterior. If you look at the, structures into the pterygopalatine fossa, they are displayed in a very, very unique fashion. In the pterygopalatine fossa, the anterior network is formed by the internal maxillary and its branches. And the posterior network is the nerve, the V2 and its branches, the pterygopalatine ganglion and its branches. And this tumor, since arises from behind, from the pterygoid wedge, as it progresses, as it enlarges, it pushes the posterior wall of the maxilla anteriorly. So it pushes all the structures anteriorly, including the vessels. So bigger the tumor, more dehiscent is the wall because of the pressure erosion, and more the vessel is pressed anteriorly. So that's a welcome, sort of thing for the surgeon. As the bigger the tumor, pushes the vessel more anteriorly. So you can identify the vessel and, take into control before dealing with the tumor. If without taking the vessel control, if you try to enter into the tumor, this bleeds heavily, and this can show what it is, and one cannot actually handle such kind of tumor endoscopically, because endoscopy requires visualization. With massive bleeding, you cannot maintain the visualization, and then you cannot remove the tumor and completely. The biggest advantage of endoscopy in such situation, it is not about avoiding a scar. That is the least of the important thing. If I enumerate, the biggest advantage of the endoscopy is the visualization it provides. It gives you bright illumination, magnification to the on-site wherever you want. And this tumor, since has a propensity to invade the various crevices, canal, fissures all around at the skull base level, it gives you opportunity to remove this tumor under vision from everywhere, which open approach doesn't. So that is the biggest advantage. The only concern is the bleeding. And if you are able to, take the bleeding in control by means of such surgical strategy, by means of good embolization, still you can remove a lot of tumor. With certain, in our practice, we have certain reservations regarding endoscopic approach. We have certain indications for the open approach, particularly if you have a vessels, when the tumor goes intracranial and it acquires vascularity from the intracranial vessels, then you cannot try to, avulse the tumor down, as it can open up the vessels intracranially and can continue to bleed. This is one of the indications. When the large vessel like carotid is 360 and case invaded, particularly in revision cases, obviously we avoid an open approach, and then we take a lot of help from the intervention radiologist and go by the open approach, sometimes with neurosurgeon by combined approach, and so many things. So there are indications for such approaches, but most of the time, particularly in primary cases, over 90% to 98% of the situations, we have been able to remove it endoscopically very efficiently, which much better is an outcome. It is the outcome which matters. If some approach gives me better outcome, if open approach gives me better outcome than endoscopy with scar and everything, I still opt the open approach. So it is ultimately the outcome which matters, because this is a benign tumor. Like any other benign tumor, The answer is complete surgical excision. If you leave the tumor behind, it is bound to come back, and we call it as a recurrence. So this so-called recurrence is actually a residual tumor left behind, which grows and become more difficult to remove and more extensive and more challenging. Now see on MRI, T2 weighted MRI, you can see the large flow voids. Can you see? This is the internal maxillary on the lateral aspect of the tumor. This is an internal maxillary. You can see the large, infratemporal fossa component. This is the nasal component. That's the sphenoid component. That's the orbital component, orbital fissure component. And if I follow it, it goes continue behind in the cavernous sinus. See the carotid artery. Can you see very clear? And the tumor
Yes.
enters the cavernous sinus and the temporal lobe from laterally, never through the sphenoid sinus. This is very important because this tumor never ever invades the sinus mucosa. So this is T2 weighted imaging. Now, how can you confirm that this is not a malignant tumor or something else? Why it is, the JNA only? See
Okay.
this. This is what a diffusion weighted imaging. Can you see this picture?
Yes.
Yes.
Is a very, very important investigation which we always advocate in these patients, and we have a couple of examples to justify it. This is basically a bioimaging. This true bioimaging from MRI. The reason being, it assesses the architecture of the tissue, what you are imaging. So in this diffusion imaging, what you assess is the motion of the water molecules in the magnetic field. So tumor which has more water content will have more diffusion. See this bright diffusion. Tumor which have less water content will show diffusion restriction, will appear dark. See this. What JNA is full of blood. JNA is nothing but lake of bloods and the vessels within it. It's nothing but lake of blood, and so it gives good. It is water and water only, and there is no diffusion restriction. And what you can see is the bright. Can you see this brightness? No diffusion restriction. Had
Yes.
this been a malignant tumor, what does a malignant tumor have? Kind of architecture? Malignant tumors have more nuclear cytoplasmic ratio, more cellularity, less water content, and had this been a malignant tumor, this entire what it appearing bright would appear as absolutely dark, and that is a crystal clear, differentiation of a benign from a malignant tumor with high specificity and sensitivity. I'll give you a couple of examples. Recently, a case was referred to us. 12-year-old child, occasional bleeding, complete nasal blockage, mass in the nasopharynx, CT was done and diagnosed as a angiofibroma. Came to us looking like JNA, but the endoscopic appearance was not really JNA. So we got MRI done and was a huge diffusion restriction. So we ultimately went in for biopsy and it appeared as a rhabdomyosarcoma. So you have to be very, very careful about the diagnosis, and this diffusion imaging will prevents you from deviating from a true diagnosis. This is really, really helping. And not only JNA, in other head neck tumors, other head neck pathologies, by 95% of the times, you can, with, quite confidence, differentiate the benign from the malignant tumors only by the diffusion imaging. The kind of diffusion restriction the tumor shows gives you a fairly good idea whether it is benign or malignant. Benign tumor have more water content, less nuclear cytoplasmic ratio, and more diffusion. And when the malignant tumor have more and more diffusion restrictions. Lymphomas have highest diffusion restriction, and many times you can diagnose lymphomas only by the diffusion MRI. That's a very, very important investigation. Now coming to the contrast, we all know this tumor being vascular takes up the contrast extensively. See the contrast imaging. This shows you, see the bunch of vessels within the tumor. Can you appreciate the large vessels within the tumor? This
Yes.
is just the network of vessels. See the kind of contrast it is taking up, and see the various extensions of the tumor. This is all one tumor with various extensions. See the center is here at the pterygoid wedge, and it is spreading circumferentially everywhere. Can you see? So
Yes.
the goal of surgery is not to enter into the tumor. exposure, exposure, exposure all around, and then pull wherever the tumor has gone back into the nasal cavity to extirpate out. So goal is very clear, not to enter into the tumor, exposure, exposure and exposure. And you'll see my 90% of the time will be invested in exposure, exposure and exposure. So that we can control the vessels on the surface of the tumor, control the principal vessel entering into the tumor, and then pull out wherever it has gone. Like in this particular case, I have a very clear strategy. See, this lateral component being too big, it cannot be accommodated in the nasal cavity at one time. Can you see? So my strategy is a planned division. See this. What I will do, this is the level of the lateral nasal wall. Can you see here?
Yes.
We'll take the vessel in control and divide the tumor in the planned fashion at the level of the lateral nasal wall. And then we'll remove the medial component of the tumor. Medial means the nasal cavity, nasopharynx, and the sphenoid component. We'll push in the oral cavity and remove from the oral cavity side. And then we'll have ample of space in the nasal cavity to accommodate the lateral component of the tumor, which will be pulled inside the nasal cavity and remove it. So that is going to be our strategy. That's a usual strategy for larger tumors with a planned division after vascular control. So first goal is vascular control, number one. Number two, see this lateral extension. So my strategy for such tumors is a modified Denkers to begin with, so that we can reach out to the most lateral aspect of the tumor with a 0-degree scope. My another strategy for this particular surgery is use of coblation on the surface. Coblation is like man of the match for this particular surgery, I call it. The reason being, the maximum vascularity for this tumor is towards the surface. And coblation gives you great opportunity to coblate the surface, whatever comes into your picture. So whatever tumor getting exposed, we keep on cobblating to shrink the tumor, to reduce the vascularity, to handle it better without bleeding, which I'm going to show you intraoperatively as well. Third is this kind of, posterior extension. See this tumor where it is going posteriorly. See, it is rising high in the intertemporal fossa, number one. This is another area where it takes additional vascularity. If you see from behind, can you see this? Can you see some vascularity coming to the tumor from behind?
Yes.
This is counterproductive. This is mostly from the middle meningeal vessel. When tumor rises high in the infratemporal fossa, this is counterproductive since we are not embolizing. So we expect some bleeding at this point of time while we avert this tumor from this vessel, and then we will pack it immediately and coagulate it, because the principal vessel we are taking into control. So it doesn't mean that you take the internal maxillary control and it is going to be totally avascular. This tumor, wherever it takes attachment, it acquires additional vascularity from the periosteum, and additional vessel, this is coming from behind, is troublesome, which we'll control with our experience using a coagulation, using Surgicel, using, Surgiflow or whatever material to control the bleeding, which I'm going to show you intraoperatively. So we are going to face some bleeding as well. Now see, from here, this tumor is rising in the inferior orbital fissure. This is orbit. This is inferior orbital fissure. This is superior orbital fissure. And then it is going towards the cavernous sinus, and this is cavernous carotid artery. See how the tumor is in relationship, close relationship with the carotid artery. But we know it has grown from anterior to posterior, going towards the carotid artery. Still, there is a good plane of periosteum intact from the carotid artery, which I am going to show you to give us good sense of relief. I would say that it is not invading the vessel per se, and we'll be able to pull the tumor the way it has gone behind. So all these extensions, believe me, would be a cakewalk once I have a thorough exposure. I will just pick up all these lateral, posterior, superior, everywhere extensions, pull them in the nasal cavity, that's it. Because they are extending everywhere, but not invading anywhere. So you have to expose and pull them back to the area of origin. Now see, in the coronal picture, about the relationship of the carotid artery to the tumor. Let me show you. See this carotid artery? Can you see the carotid artery cavernous?
Yes, yeah, you can.
Now see why I'm showing it is saying that it is not invading. Let me change the window setting and see the periosteum which is enhancing. See, I'm changing the window setting. Can you see the enhancing periosteum all around? See, periosteum
Yes,
of the
that looks
carotid
like that.
enhances. This is a very well defined plane between the, see, this is the plane between the tumor and the carotid artery. Can you see very clear?
Yes.
Yes.
That's the kind of MRI you need to give you amazing information. See, how to order the imaging. Again, the onus lies on the surgeon. If you order an MRI PNS, the radiologist will do 1 or 2 sequence and get away. Because every sequence has to be shot separately and it takes a lot of time and money. So the onus is on the surgeon when you suspect some pathology, that what kind of MRI to be ordered. So in this particular case, we order CT angiogram, carotids, T2 weighted fat suppressed MRI, contrast multiplanar MRI, axial coronal sagittal sections, a diffusion weighted imaging to complete your imaging protocol. If you don't order and just order MRI PNS, the radiologist will do 1 or 2 sequence and get away in 5 minutes. So onus is again the surgeon. Many a time, you know what happens? Patient come to us with the MRI in the hand. MRI a printout in the hand, which is as good as useless to us. We need this kind of dynamic imaging, a complete comprehensive imaging, and unfortunately, we are forced to order the MRI again with this kind of protocol. So this is something we always propagate. Once you suspect some pathology, you must order complete sequences in your prescription so the complete comprehensive MRI can be done in DICOM format. This is a dynamic MRI. You can compare all the 3 sequences and run together to have a complete 3D information. So this is about imaging. Our case is induced. We are ready to go. Meantime, we are ready to take up any questions, any suggestion. Dr. Rekade, you want me to show anything more on imaging?
No, fine. There is a question about, you probably have already answered those questions. Like, what is your standard investigation protocol for these patients when they walk in the clinic with the suspected monster that we discussed? Other question was, when do you do the biopsies? When do you consider a biopsy of this? So that also, in a way, you answered that diffusion weighted.
I have answered, and I will repeat again. Yeah. Get diffusion imaging. If you have a doubt on diffusion imaging showing restriction, it can be something else than JNA, and then you have to plan a biopsy. Yes. Any other question?
Having seen all these extensions and in your experience, any recurrent JNAs and all that, have you ever have to consider radiotherapy as a treatment modality, and never. What that situation will be?
I would say never. See,
never.
JNA diagnosis itself is frightening for the surgeon, particularly with such kind of extensions. Like this can be considered intracranial extension. It is intracranial going into the cavernous sinus, no doubt about it. And it has been traditionally discussed that with such difficult extension where chances of complications are more with the surgical exercise, we remove the tumor partially and advocate radiation. This is, I would say, ridiculous in such patient to advocate radiation. These are young patients. Radiation has its own, implications, complications, long-term complications, including future development of malignancy, and we never order. With the improvement in the surgical technique, with the improvement in the imaging technique, with the instrumentation, equipments, camera system, telescopes, image-guided system, now the surgical, field has grown so big, and we have been able to remove such tumor. I have shown you the MRI, giving me clear picture that tumor is not invading the carotid artery. It is approaching, and we can still remove it endoscopically without any fear. So if you have a good exposure, there is no point in subjecting such patient to radiation. This is ridiculous. Radiation is indicated, let me tell you, in our setup. We get sometimes multiple operated, revision surgeries. The patient operated 5 times, 7 times with true invasion. See, once the primary tumor, I would say this JNA primary tumor is a well-behaved tumor. It has a predictable extension. It has a predictable vascularity, you can say. Now, what happens once you take this vascularity in control and leave the tumor behind, then it acquires aberrant vascularity. Got my point? And many times it becomes more purely invasive tumors. We have seen tumors truly invading the brain tissue, revision cases. We have seen tumor truly invading the carotid artery because they acquire aberrant vascularity from the internal carotid system and become more and more invasive. And in those situations, your surgical exercise should be accordingly, directed. And many times we have to resort to the open approach, as I said earlier, for more and more help from the intervention radiologist. And still, if it is truly invading the vessel and the hemorrhage is imminent, you are forced to leave behind some part of the tumor, and then you are forced to radiate. You are forced to radiate. Radiation is never in your primary protocol. In those unfortunate situations, you are forced to radiate to prevent tumor growth, because radiation doesn't kill the tumor. It incites fibrosis. It invites fibrosis in the vessel supplying the tumor, and it ultimately contains the growth of the tumor. It doesn't kill the tumor. So it can regrow again. It can convert to malignant tumor, frank malignancy. We have seen converting into angiosarcomas after radiation. We have got such cases. So this is how our protocol for radiation, which is never in the primary list.
Thank you. And in your vast experience, you're probably one of the world's largest series of JNAs, and you've seen all the extensive ones. What is the youngest patient you have to operate on with JNA?
Youngest patient I have operated is a 7-year-old child, a very big tumor. Very big tumor. And this is again a big concern. Children have less blood volume. The tumor is more aggressive. And particularly when the tumor comes far anteriorly towards the anterior nares, it becomes so difficult to negotiate your endoscope as well. And many a times in children, because the surgical time again is a big issue in children with the ongoing bleeding. Many a times you may have to, taking in all these things into consideration, with kind of tumor going anteriorly, big tumor, you may have to resort with the help of intervention radiologists, or ultimately you may have to resort to open surgery with the help of endoscopy, some sort of thing, because you have to take into account all these things in young patients. Elderly, I have operated JNA in a patient who has been operated 7 times earlier, and a 40-year-old patient. 48-year-old patient ultimately invaded the brain and turned into angiosarcoma. So it all depends upon, the pathology. So the bottom line is, this is a primary tumor, and complete removal is the only way to cure. So we should put in everything regarding imaging. Imaging is the best exercise to gauge the true extensions of tumor. With inadequate imaging, you can miss the tumor behind, and again, it can come back. That's why I always advocate, see carefully where the tumor is going. See this. Many a time what happens? See, this is the pterygoid process. Can you see? This is the greater wing of the sphenoid. This tumor has a propensity to invade the marrow bone, particularly the marrow bone of the sphenoid and the clivus, which may be easily missed on surface visualization. Your true imaging will tell you that it has invaded the marrow bone, and then complete removal is the key. You have to completely remove that bone in spite of looking normal on superficial visualization. And this is here, our T2 weighted imaging is crucial. Look at this T2 weighted imaging. This is fat suppress imaging. Can you see? This is our one of the primary, sequence, fat suppress imaging. Fat suppress imaging means it suppresses the fat. Everywhere, see, wherever the fat is, see dark. Now, the pterygoid bone and the sphenoid bone, this greater wing of sphenoid, contains the marrow, and marrow contains the fat. So wherever is the fat, it enhances. On a regular T2 weighted, it enhances. On fat suppresses, it doesn't enhance. Now see in this particular imaging, look at the right side of the pterygoid process. It is absolutely dark because the fat is suppressed. Now look at this. Look at this side. This is dark, absolutely dark. Can you see on the right side?
Yes.
Now look at the left side. It is enhancing. What is this? The tumor is infiltrated by the, this marrow space is infiltrated by the tumor. Had there been fat only, it would have been suppressed on fat suppressed MRI. In spite of the fat suppressed MRI, you are seeing hyper intense signal. What is that? It cannot be anything else than tumor. Now this bone on surface visualization, even on endoscopy, may appear normal to you. But I know from imaging that marrow is invaded by the tumor with this fat suppressed imaging. And this is the indication for extensive removal of the pterygoids. So you can remove the microscopic tumor which is contained within the marrow spaces. Otherwise, it is going to come back. You know, if you see the largest of the series of the revision surgeries, recurrences, whatever, the biggest reason behind the so-called recurrence is the tumor left behind in the pterygoid space, in the pterygoid bone, in the sphenoid bone, in the marrow spaces, which was overlooked by the previous surgeon because of inadequate imaging. I tell you, honestly, that's the only reason. Inadequate imaging, the surgeon doesn't know where the tumor is going deep into beyond the visualization, and then it is bound to come back. Once it comes back, it is going to be more difficult. Any revision surgery is 1,000 times challenging than a primary surgery by all means. So this is how an imaging can save you from the biggest of the recurrences, and that's how I always advocate. See, this for last almost 1 hour, we have been discussing about imaging. This is most important, a tool, believe me, for surgeons to guide. We have now complete information about all the extensions. We have now complete information about the vascularity and the cross flow. We have complete information about the hidden aspect of the tumor in the pterygoid and the sphenoid bone. Can you see? And this is what we expect from the imaging. You know, imaging is technology, and technology is growing at a much bigger pace than the surgical science. And we have to take, now is the time to take the advantage of this technology. And this is what these workshops are the platform to exchange our ideas. And this is always we propagate that your imaging should be adequate, and one should himself, the surgeon should himself or herself be able to read the imaging, because this kind of information cannot be given by the radiologist. We need dynamic information. We need information from surgical point of view. It's not that the static information, tumor is going here and there and there. We can know that, get to know. But how the vessels are entering, how the tumor is growing, how the bone spaces are involved, this best information to be printed 3D in the surgeon mind can be gauged when the surgeon himself reads the imaging. So we should be able to read imaging ourselves to get more adequate information. This is what our message is. Any other question, Dr. Rakade, before we get on to the surgical?
I really look forward to that surgery now. That was absolute radiology masterclass on the JNA. So did all the details and each and every vessel. That was amazing. We saw all the branches of external carotid and we traced that to their destination. That was great.
Thank you.
The message here is investigated thoroughly with the CT, MRIs, then a request for appropriate information, and look for all the vascular information on your imaging studies, and so plan your surgical strategy. So look forward to joining you there.
Thank you. So, and feel free to interrupt me during surgery as well for any questions or any queries or any suggestions, any point of time. I would love to be interrupted for more and more discussion. And thank you, Dr. Lewis. Any questions from your side or any suggestion before we embark on the surgical part?
Well, I mean, I think you've answered the question, but obviously it's very extensive, and the prognosis, so you would be aiming for a complete clearance of this tumour today.
Thank you.
Is that right?
Thank you. So in a couple of minutes, I'll be back with the endoscopic picture now. Thank you.
Right. Yeah, sorry, I don't think he heard it there, but
That's okay.
that's probably that was he was alluding to that. He should
Yes, I
be
think
aiming for
so.
complete surgery.
That's right.
That just
And I think
incredible, isn't it? It's
it
such
is. It
an
actually is
extensive
incredible.
tumor.
It's so extensive, so extensive. But I
And
think
that
it's
too
just
without
with his
embolization.
experience with the endoscopic resection. That's right.
Correct. And
That's right. So
the
I'm
patient
really
hasn't
looking
had
forward to seeing this.
embolization.
It'll be excellent to see. And I think the point as well of the correct protocols for your scans and the responsibility being on the surgeon to ask for those. Because it's very true. I think when you've got a good relationship with the radiologist in your department, you know, they know what scans, what protocols, what you need, but you know, I think it is on us to ask for the correct protocols so that we get the information that we need to do the surgery safely.
Yep. And there is more and more tendency towards relying on the radiologists to plan that
That's
and
right.
provide that information. So it just highlights that the surgeon himself have to be sort of very dynamically involved into getting that information. That helps
Absolutely.
for surgical planning. It was very beautifully taken through all the 3D planes to get that, in his own words, you need to have a 3D printout of the tumor in your own mind before taking the surgery. Then again, use of coblation, so that will be great. And seeing that tumor division, I think important point that he makes is that main vascularity of the tumor is along the surface. So you control the surface and then go through the core with coblation. That seems to be the strategy.
Yes.
And nonetheless, that having IMAX control, the main vessel control, doesn't guarantee that suddenly the tumor becomes avascular. So you still have to be vigilant and be prepared to control the bleeding from the other side. Like in this case, looks like there's some connections from the middle meningeal area.
Yes. And he's prepared to deal with these if that happens.
Right.
But I think it's quite incredible actually. I think because I think looking at that tumor, I think certainly in the UK there would there'd be a lot of hesitation with such an extensive tumor.
Yeah, correct. And we don't see that many numbers, and having that high volume, and this again underlines the importance of having high volume centers. They can provide better outcomes for these patients.
I think as well with JNA, there's the added stress that it's often a child, and also it's a benign pathology. You know, we spend so much time dealing with malignant pathology, whereby, you know what the outcome is if you don't operate, so you can balance the risks of the surgery.
Right.
You know, but I think the JNA is very unique in the concerns that you have.
नहीं यार से उम्मीद नहीं थी उम्मीद नहीं थी दूसरा कैमरा लेता ना टेलीस्कोप अच्छा ले लेता और अच्छे 4-5 है यार देखना यार
Hello, yes, Dr. Satish.
Yeah, so we are with the endoscopic picture now.
We're ready.
Let me know if you get the endoscopic picture.
Yes, we can see the endoscopic picture. See you're aspirating the mucus.
Yes, so this is all infiltrated secretions. This is the inferior turbinate on this side. And see the tumor behind. Can you see?
Yes.
Yes.
And see the nasal space, which is not very big, not very, I would say, it's a narrow space. what I'm using first, is the decongestion. I'm using these marrow cell pieces soaked in adrenaline to decongest the nasal cavity and some gauze pieces. This, this is tumor, so I can afford to use the gauze pieces. In endoscopic sinus surgery, we don't use gauze pieces, more and more marrow cell to respect the mucociliary activity. But here, this is not immunocompromised situation like, sinus surgery. And see, just applying the topical adrenaline. Our first application will decongest the capillaries and open up the space and prevents its systemic absorption. We never inject in the nose for anything. Can you see after the first application?
Yes, yeah, I can see.
See
much,
how the nasal space has opened up. See, much better now?
Yes.
So this initial preparation is very, very important. See, in endoscopy, the visualization is the key. And to maintain in order to maintain the visualization, the bleeding should be minimum. And this is afforded by your all the help from the decongestant, from the anesthesiologist. This is one surgery, unlike sinus surgery, where we go for or request our anesthesiologist to give hypotensive anesthesia. This is one surgery. In sinus surgery, we never ask for hypotensive anesthesia because there the source of bleeding is capillaries, and here pure arterial bleeding is expected. So we expect our anesthesiologist to give hypotensive anesthesia. We load these patients with a fluid, with starch, whatever, so that whatever bleeding happens is the diluted blood. So there are a lot of strategies from the anesthesiologist side to help this tumor removal by endoscopic approach. See this tumor which was rising up, that's not invading anywhere. Can you see?
Yes. Yeah.
Which I'm pushing down with my gauze pieces and see the middle tablet in front of you. So this is how you can see how the tumor, this is tumor, and from the surface you can see it is looking, angry. This angry looking picture is classical of Jain-Case. Now, my man of the match tool which is coming into the field. This is what? Coagulation, and this is the vent I am using is a Pro Size Max, and see what I am doing. This is my man of the match tool. I am doing surface coagulation. Can you see?
Yes. Yeah.
This.
So what are the settings, Dr. Satish? You use coagulation?
Yeah, full on 9 and 5. देखा तो करो पहले. See this? This is giving surface coagulation. Can you see?
Yes.
This particular tool is a wonder tool which has the ability to irrigate all the time. Can you see this? It has the ability to coagulate. It has the ability to cut as well. One tool along with the suction to take away the blood and the secretion from the field to give you amazing visualization. See during entire surgery, this one tool will be working and giving you all the things which you expect. So what I'm doing is surface coagulation, because at any point of time you happen to touch this tumor with your instrument, it starts bleeding. So this surface coagulation, first of all, takes the surface in control to prevent bleeding with the instrument. Number two, it shrinks the tumor as well. See, maximum bleeding in this tumor is toward the surface. As the tumor grows bigger and bigger, the more and more central part become necrotic. So this is how this tumor has to be accordingly handled. See, whatever tumor which comes in your view, keep coagulating on the surface. See how the surface is being coagulated. Can you see clearly?
Yes. Yeah.
I hope the picture is good there.
Yeah, it's a very good quality. You can see it very clearly.
Yeah.
Thank you.
Thank you. Let me know for anything I can do more
Yeah.
regarding
We can
picture
see that tumor is
and
getting is shrinking down as well. So more and more landmarks are coming in view. We could just had a glimpse of middle turbinate.
And I'm grateful to Mr. Dinesh for this telecast. I am so used to working with him as a sort of addiction he has given. The kind of comfort he gives with the live telecast is amazing.
Yeah, it's a fantastic work, and the quality of transmission is really wonderful.
See now the surface. Now the more nasal cavity has opened up, and this wonder tool, which has all abilities. Now, I told you in the beginning, we will never think of entering into the tumor in the beginning before taking the vascularity in control and before adequate exposure. Okay. So now my first part of the exposure will involve a modified Denkers. Modified Denkers means, see, this tumor has gone laterally and there's a lateral wall of the nose which is the biggest obstacle to to reach out the tumor. So we have to remove this lateral wall of the nose or the medial wall of the maxilla along with the anterolateral wall to get on to the most lateral part of the tumor head on with 0-degree endoscope. So this is the modified Denkers approach described by Sternman and Canfield is amazing. It gives you a good paramedian highway to approach all these tumors. And so in order to remove all this, my landmarks are, my superior limit is the orbit. I will show you under vision how we spare entering into the orbit, how we stay away from the orbit. So in the beginning, again my tool will be coagulation. This is the axilla. So I stay roughly a centimeter below the axilla and coagulate this periosteum. See, this is a richly vascularized area. And see coagulation. It takes care of all the, with the coagulator. See, we can coagulate the surface to minimize the bleeding. This is my man of the match. So this involves removal of the maxilla, medial wall of the maxilla and the inferior turbinate, which is a separate bone. See this? I am coagulating not only the medial wall of the maxilla, but the inferior turbinate as well, which is a separate bone, and this inferior meatus as well, so that we can flush the bone removal up to the floor of the nose. And see
Satish, there's a question for you. That there is a question for you.
Yeah.
That we haven't seen the navigation mentioned yet. So
navigation, most
do
of
you
the
use
time
surgical
not
navigation? Good. Not,
navigation most of the time not needed, yet it helps you improving your localization. With experience, the need for that is more and more reduced. I am not agreeing. If you feel like using it, you can use it. Now see, this is the initial coagulation. See this? And my anterior limit is this bone. This is pyriform aperture. And we are not supposed to go far anteriorly here. See, almost a centimeter anteriorly here. This is the lower ala, which should never be destroyed. Otherwise, it will give some deformity and need some rhinoplasty correction. Now, my next goal is I am using the cutting for the first time and remove this periosteum. See, removing this periosteum to expose the bone now. Can you see?
Yes, sir.
What an amazing cutting tool with no bleeding at all. That's the beauty of the coagulator. See the visualization. Endoscopy means visualization. See, my coagulator gives me amazing opportunity to go bloodless. And see, I will show you my anterior limit soon. Can you see the bone of the pyriform aperture now?
Mm-hmm.
Yes, very clearly. Yes.
This is my anterior limit. See, this is our anterior limit. and my lower limit is going to be till the floor of the nose. Wherever is the bleeding, you can always use the population immediately. See, from top to bottom, the entire pyriform aperture. Can you see the pyriform aperture thoroughly now?
Yes.
Yes.
See this. Now I told you this is a separate bone. This inferior turbinate is a separate bone. See this turbinate? Can you see this?
Yes.
Yes.
This is the turbinate. Later. Find all. See, I have fractured the turbinate like this. That's a separate bone. Yes. Now I am removing this periosteum of the inferior meatus. Can you see?
Yes.
Yes.
And see, my lower limit is the floor of the nose. See this? Completely flush. Now this cobbleator helps you control this thing much better because the inferior turbinate gets its milk from the vessel, which is a branch of spine runs through the turbinate from behind. Still, the cobbleator helps you control that bleeding effectively. यहाँ से जा रहा है यार हटा See this? This turbinate has to be removed to expose my lateral wall thoroughly.
And do you use a cobbleator for all your tumor work?
Pardon?
Do you always use the cobbleator for your tumor work?
Yes, yes.
Yes.
Always. Cobbleator is the key for everything. See the kind of comfort my one hand is using cobbleator. Other hand, I am holding the endoscope, and this cobbleator has everything: suction, irrigation, cutting, coagulation, everything in one in this magic wand.
So you're cobbleting all the soft tissue, turbinate soft tissue, really.
Yes, see, there's no bleeding at all. And we are reaching more and more behind without any issue. See this?
Yes.
This is a tumor. This is a one component which has various extension, and we have to expose all. And all the intervening bone has to go. The principle behind this surgery, efficient, I would say, endoscopic surgery, is the exposure. Inadequate exposure will invite complications. दूसरी बैंड भी रखना वाला See this? Till this? Now the entire lateral wall is exposed. See completely?
Yes.
We have dealt with this extremely vascular structure without any issues. Now, see this, the pyriform aperture. Now I will go towards the anterolateral wall, and this tumor has massive lateral extension as well. See this? Subperiosteal towards the anterolateral wall suction. And see, it severs lot of neurovascular bundles. See this carefully.
Yes.
These are all superior alveolar neurovascular bundles. See the now anterosuperior alveolar nerve branch. And we have to sever this to reach laterally. My usual lateral limit is the V2. Usual lateral limit. If you really want to go further for more lateral extension, there's a technique described by Professor Paul Casanova as V2 transposition. If you transpose the V2, you can go 360 degree even all around and beyond. See, this is the V2. Can you see this?
Yes.
Yes. Yeah.
This is the inferior orbital foramen. So right now I'm not going beyond that. It's not needed in this particular case. And see,
Do you develop any numbness afterwards? Any temporary numbness?
for a couple of weeks, definite numbness because it supplies all the canines and the incisors, upper canines and incisors, and this now has numerous, ramification, communications. Ultimately, it regenerates, with other branches, and most of the time it doesn't bother in long run. So this is expected that you have to tell your patient before as well. See this bone exposure. Niche section. Complete exposure of this bone. See here. Now I will punch out this thin bone, anterior bone, and then will enter the maxillary sinus. This is the thin bone can be punched out with a lux forceps, or any bone punch, whatever. See this? Drill. And now I am going to use with my high-speed drill this state-of-the-art Medtronic. See this? This is transnasal burr, which is a inherent 15-degree curvature in the shaft. So the shaft doesn't come in the way. See what I am doing? To show you my superior limit. I want to see my superior limit of the maxillary sinus first, so as to avoid unnecessary entry into the orbit. See now I have entered into the maxillary sinus head on. Can you see?
Yes.
Yes.
Yeah.
Which will show you inside picture soon. Let me widen a little bit. Action. See the interior of the maxillary sinus. See that?
Yes.
And what I
Yes.
intend to see is my superior limit. With this Jain-Case, I don't want to damage the orbit. I don't want the unnecessary, unwanted orbital entry. So until the orbital roof, I can go up. And 3. इसको पकड़ा दिया तुमने. Section. He's just showing you the orbital roof, orbital floor, sorry. The sinus roof, which is my superior limit. I want to expose this sinus roof thoroughly so that I can define my superior limit adequately. See now inside this prominence in the medial wall. This prominence here belongs to the nasolacrimal duct. Hello?
Yes.
In this surgery, the only important structure which comes your way, only vital structure which comes your way is the nasolacrimal duct. And you have to obviously transact it to go ahead because it comes in your way. The best way to prevent epiphora is to cut it flush with the level of the orbital floor. If you cut flush with the level of the orbital floor, it doesn't come your way. Let me show you. इधर सक्शन कर हल्का से हल्का always. See this? This is your entry into the maxilla. Can you see the level of the orbital roof? Orbital floor?
Yes.
And this is the level you have to remove this bone until then. So, since the bone is thinned out, so I can afford to remove with my punch again. See this? Under vision more precisely, and see behind is your nasolacrimal system.
Mhm.
Can you see the nasolacrimal duct?
Yes.
This is your nasolacrimal duct, this one. I hope it is very clear.
Yes, you can see that.
Nasolacrimal duct. So we will flush this bone until the level of the floor of the nose. So that I can cut it flush to prevent an overhanging duct. This is a strategy to prevent this duct getting fibrous and giving epiphora. पानी भी ले सक्शन भी ले उसको देना है एक काम तो ढंग से कर ले यार बंद करो see where is soft tissue bleeding, you can use your cobblator. See this?
Yes.
My duct is very much, hanging in my field. Can you see very clear?
Mhm.
I will further improve my, exposure. Some more lateral first. जाके डाल ले छोड़ गुस्सा दिलाता है चला See, all this bone I have to flush with the floor. Can you see?
Mhm.
This is important so it doesn't upset the instrument, deeper instrument. It should be thought flush with the lower one. So I am quickly flushing it with the floor. Action. Just to reorient you. This is the lower bone I am removing.
And does this approach always give you enough of a lateral access, or do you sometimes have to combine it with coming from the contralateral side through the septum?
Contralateral side. Hello?
Yeah, sorry, can you hear me? Does this approach usually give you enough access to the most lateral extent, or do you sometimes need to combine it with an approach coming from the contralateral side through the nasal septum?
Yes. So in our strategy, I will come later. Whenever this tumor grows towards the midline, it can acquire the vascularity from the contralateral circulation. So we are very careful about that and control. I will show you once I will reach to the midline when we separate the tumor from the nasal septum and the nasopharyngeal roof. Can you see the maxilla head on, maxillary sinus?
Yes.
So I will get more exposure by flushing with the floor. This flushing with the floor is very important. This is very important for your instrumentation later on. Flush. See this? The brighter. See everywhere. The more and more exposure is the key. I have removed the part of the lateral wall. See I have defined my level of the roof of the maxillary sinus. Can you see very clear?
Yes.
I have defined the level of the floor of the maxillary sinus, level of the floor of the nasal cavity. Here, can you see?
Yes.
This is my required lateral exposure, This is very, very important to have adequate exposure. Now I will remove this bone, the thin bone, and will remove all this lateral wall bone until the posterior wall. This all lateral wall bone until the maxilla. This is the uncinate process now behind. See what I am taking out. And flushing with the floor. Everything coming in the way has to go until the posterior wall. Quickly. Debrider. And see the nasolacrimal duct overhanging, which will take. See the posterior wall of the maxillary.
Yes.
See, this is the remnant of the uncinate process. This is, let me show you my nasolacrimal duct. See this? Getting it out of the bone. Out of the canal bone. See this?
Yeah.
I'll remove this entire bone all around. I am removing this entire bone all around. The brighter. See the entire bone all around being taken care of. Can you see all around?
Yes.
See the nasolacrimal duct overhanging. There is nothing all around. And now this is the time to do a sharp transaction. See this? The sharp transaction of the nasolacrimal duct. Can you see above?
Yes.
See, this is the nasolacrimal duct which has been transected. See? So now it doesn't overhang. It's not going to come into our field anymore. What my point? And this, since it is not going to overhang below, this is not going to get fibros and give epiphora.
Mm-hmm.
If otherwise, if it gives, you need to do a proper endoscopic DCR further. See now, the posterior wall is flush with the lateral wall. Very clear? Now a little bit of the lower part is still there, drill, which I am going to flush with. Viru, honey. See this, the wall of the maxilla? This I will flush thoroughly with the floor. Till posterior wall. Everything has to be thoroughly flushed.
And is this the 15-degree transnasal burr that you're using?
Yeah, so this is, let me tell you, this is a wonder burr. See, this is pure transnasal, such a sleek burr with a natural 15-degree curvature. So when you use inside, your sharp doesn't come in the way. But my point?
And is that is this a coarse diamond burr?
I was using at a speed of 60,000 to 70,000 RPM. This is a single-use burr. Cost is a limiting factor, but this is simply amazing. Simply amazing tool for the skull-based work.
Yeah, and the burr that you're using, is it the coarse diamond burr?
Yeah,
it's not a cutting burr.
Yes,
coarse diamond.
Absolutely. This is very, very safe. Coarse diamond burr. With I'm using the 0.5 mm coarse diamond burr. See, wherever the soft tissue bleeding is, you have to use the coblation. Now more tumor is coming into picture. See this? More and more surface coagulation is required. More and more surface coagulation. This tumor has a propensity to invade certain structures and spare certain structures. This tumor, as I said earlier, never invades the paranasal sinus mucosa. See this? This tumor preferentially invades the turbinate and the septum. This is middle turbinate, which is almost always an attachment with the tumor. See this? So wherever the mucosal surface, I am coagulating to improve my field. And see the value of coagulation. Simply amazing. Now behind this paranasal sinus mucosa here, see, I am removing this maxillary sinus mucosa thoroughly. See this?
Yes.
Behind that is the pterygopalatine fossa, which is our area of interest. See, only one tool is working, that is coagulator.
And you've got thinning of the bone there, and it's all the tumors breaking through.
Yes, you're right. See this bone, it is bulging. Can you see this?
Yes.
Because of the tumor pressure from behind. The huge tumor
Dr.
behind.
Satish,
Yes.
apart from this JNA situation, do you use a coagulator in any other sinus surgeries?
Yeah, not in sinus surgery. Adenoidectomy, it show you in based procedures. In CS synovial, I will show you the case today. And all based procedures, even in the intracranial procedures, it is very, very safe to be used even on the brain.
Okay. or even difficult nasal polyps which are bleeding, you tend to use them.
So here, but it has to be used judiciously whenever you are using the cutting part, because cutting is ability very fast, you know. And see here on the bony surface, I am not using complex bony surface, but that will ruin my blade. So bony surface, I am using this. Okay, can you see that?
Yes.
Never use
Yes.
the complex. It is only- Yeah. So this is my initial part of the exposure after the dankers. Can you see very clear?
Yes. Yeah. That's
Now what
amazing.
you
Very
see in
wide.
front,
Good.
what you see in front is your posterior wall of the maxilla. And we have reached now head on. See the entire surgery, in spite of extreme lateral and superior extension, throughout the course, I'll be using only 0 degree. 0 degree gives you best visualization without any disorientation. And the principle of skull base is to use 0 degree, 0 degree, 0 degree, except in certain situations when you have to look into the corners, you can use angled scopes. But the primary scope is 0 degree, always. See, the entire maxilla is exposed thoroughly. Can you see very clear now?
Yes.
And all the time, the visualization has to be improved with. Visualization has to be improved with coagulation, coagulation, except on the bone. Yes. So this is my initial, exposure, and see the bloodless field. See the bloodless field. My next goal is to get into the pterygopalatine fossa. This bone is the thing which is in between, which has to be removed. See now, because of the tumor pressure, this bone becomes more thin. More the tumor pressure behind, more the thin bone it is. Yes? Many times it is paper thin. I can thin out and remove this bone with my drill. I can use my chisel and hammer. I can use my punches, anything. See, I'm using light. See this cracking the bone with the chisel and hammer. It has become so thin. Look, I can remove this bone like this.
Wow. You're opening the door.
Yes. So now the next structure we come across is the pterygopalatine fossa periosteum. See this? The pterygopalatine fossa periosteum. I am coagulating the periosteum just to maintain the field. See this? I hope the picture is clear.
Yes.
With the curious. Now I can use safely the punch. See this? Expose more and more. You have this tumor far behind and lateral and up. Everywhere. Okay. Behind the periosteum, would be the tumor, and on the surface of the tumor would be the vessels. कर दिया अब करने का काम करता है ठीक है यार See more and more exposure. I am removing more and more bunch. See how the tumor is bulging. I am removing this entire intervening bone. All bone being removed. See all intervening bone between this part of the tumor and this part of the tumor. Divider. See all intervening bone coagulation. Now a little bit of potassium. See the fat coming from the you see
Yes.
further coagulating on the surface to optimize my field. See this field. This is the turbinate. See this?
Yeah.
I am taking out part of the lower part of the turbinate in between to show you both parts of the tumor in continuity. See both parts of the tumor. See this? That's the
Yes.
bottleneck. Can you see the bottleneck?
Yes.
See the
coming out of that.
bottleneck. That's a part of the turbinate. See my nasolacrimal duct up in the field. Can you see?
Yes.
But not
Yes.
bothering us. Not bothering us. We have cut it sharp above. Now see this part of the clip. All intervening bone has been removed. See this? Now my next course, Uday, put up. My next course is to, catch the vessel before going further anywhere. Just leave it. Now see, we have to go behind this periosteum to catch the vessel. Okay? One of the most important part of the surgery. This is level of the floor. We know where the vessel is likely to be. What I am doing here, See, I am cutting the sickle, the periosteum to open up this space. Can you see the tumor?
Yes.
Yes.
See, I have opened the periosteum. And see, this is tumor, pure tumor. I am taking away the periosteum. This rest of the periosteum. Tumor is bulging. This is a tumor. Now, in this lake of tumors, you have to identify the vessel. Big challenge. Big way. I'm trying to segregate and identifying the vessel. Can you see?
Yes.
Some fat which is prolapsing, which I am going to, remove and empty this field. This is the fat I am removing.
So again, a very similar technique using continue with the coblation.
Coblation is the key. Uthaya. Now the goal is to look for the vessel. Can you see the vessel?
I can see that.
This vessel has a tortuous course in fossa and the intratemporal fossa. Tortuous cobbleton with the tumor coming in between. See this? I am first here. Yeah. Can you see this vessel?
Yes.
Which I am looping. See this? See the big vessel?
Yes.
Yes.
And now here, I am putting a clip over it. See this? नहीं हाथ आ रहा तेरा.
Yeah, see there.
No, give me one more. हाथ आ रहा है. दिल बहुत रहा है. बहुत चल रहा है. एक्शन करो. This is one vessel. To me, that look the main vessel supplying. So I will coagulate it. See this? Hello.
Yes.
Yes,
Yes.
yes. So very nicely dissected. And so far, there are hardly any bleeding, isn't it?
Yeah.
Mhm.
Probably.
Yes. Yes. So I'm looking for the trunk now.
So is that the main trunk that we saw on the scan that you're exploring now?
Can you see this?
Do you need? Yes.
This
Yes,
is the main
yes.
trunk.
That's very
This is
clear.
the main
Yeah,
trunk. यूं पकड़
that's
के.
the main trunk. And that's the one we saw on the scan, correct?
Yes. And now I will put my clip.
Look around it.
Clip is the most secure way of taking this vessel in control. See this?
Yep.
A coagulation can reopen later on.
Mhm.
I will, on a safer side, use multiple clips. See, the tumor pushes the vessel anteriorly. इसको काम दे दिया.
Do you ever have to ligate the internal maxillary artery again as you come
Yes.
round laterally and posteriorly?
Posterior, I have seen this entering the tumor from within, not anteriorly many a times, within the lobulations of the tumor, and that's difficult to dissect it off.
Mhm.
So your CT angiogram can actually tell you what exactly the course of the vessel. That's why CT angiogram is damn useful. See this vessel now?
Yes.
Clipped
You're
on
dividing
either
the
side.
population again.
Clipped on the either side. And I'm transecting it. See this?
Yeah.
Yes.
Yes, control.
Giving the major, devascularization of this tumor. No, this is not devascularization to the level of the capillaries. We call it intraoperative embolization without actually doing embolization. Cutting चल गई हो. See now, once you are devascularized, by mistake I, pressed on the cutting. So just went into the tumor, so it started. So what you can do, you can use your Surgicel and leave it for a while. No issues. You have devascularized. This is one component you have exposed. See the lateral part of the exposure? We have done anterior exposure, we have done anterolateral exposure. Can you see very clear?
Mhm.
Yes,
Yes.
yeah, we can see the two components very clearly.
And now we will go all around. We will do superior exposure and separate from the paranasal sinuses. We'll do medial exposure, go across the posterior part of the septum to go to the nasopharyngeal roof. See this tumor going in the different
Yes.
lobulations? Yeah, upper section. Yes. And see, this is the turbinate, which is which was bothering earlier. See, just read it up. I am
I think
cutting
this is a
a
good time to
little more.
summarize the case, really, for the sake of those who have joined a little later. I think Dr. Satish Jain from Jaipur in India is demonstrating surgical procedures today. We have our final day, third day of our live surgical event. We have very interesting cases lined up. So this case particularly, very extensive journey in a 12-year-old. It has not been embolized. We've gone through the imaging studies, through the CT and MR. We looked at all three planars. So we looked at
What I'm
the
doing.
tumor is extending laterally, then into pterygopalatine fossa, then again into along the infraorbital fissure, along the sphenoid towards the cavernous sinus. So
Sir,
the
can I
surgical
interrupt you?
strategy here is extensive use of coblation and then a modified Denker's approach. So surrounding the tumor and then trying to aim for the main feeding vessel, which is IMAX. We just saw that Dr. Satish has explored the IMAX and had ligated, like put some ligature clips around it and then divided it with the cobbleter. So it's a beautiful demonstration of how to use a coblation for surface coagulation and then deal with the tumor. So getting a good hemostasis, good exposure before you get to the tumor. So the strategy is to tumor as two distinct parts, the medial and lateral, to divide in the center and then deal with them separately. So thank you. Anything to add, Luis?
Boss, I am doing ethmoidectomy now. I am superior to the tumor. See, the tumor is below. This is one component which is extending up. Give me a gauge piece, small gauge piece, to push it down. See this component, this lobule of the tumor. And what I have done is anterior ethmoidectomy, keeping my lamina papyracea as my lateral limit. To show you something, I told you this tumor can rise high in the ethmoidal roof or even, erode the ethmoidal skull base, but doesn't involve the mucosa. And see, this is the ethmoidal cavity. And keeping my lamina papyracea as a lateral limit. This is lamina papyracea. See this. Doing my ethmoidectomy and going behind. See, there is no tumor in the ethmoids. Can you see?
Yes.
Yes, they're
Very
clear.
clear.
See, superiorly, the ethmoidal cavity is crystal clear. Now, this is your superior turbinate. I am removing part of the superior turbinate with my shaver only. Yes. Now look at the ethmoidal cavity. Very clear?
Yes.
Mhm.
It's staying on the top of the tumor. See this? I am removing this ethmoidal floor. See this?
Mhm.
See all the way tumor.
Yes.
I am giving superior exposure of this tumor. This is superior exposure. This is superior exposure. All ethmoidectomy everywhere. The brighter. Funny. See now, this is, can you see?
Yes.
This is ONOD cell. See the optic now. That is ONOD. Can you see that? Beyond that is ONOD. That's the optic now. Now my sphenoid is pushed medially and inferiorly. See there. Now this is the part of the superior turbinate which I am removing. To enter into the sphenoid sinus. Let me remove this part of the tumor later. This tumor which is coming in the instrumentation and bleeding again and again. See this? The small of the tumor which is superior medially. This one. Now my sphenoid is here behind. See this? See the tumor within the sphenoid sinus. Can you see?
Yes. Yeah.
Clearer for you. Part of the superior turbinate. And this is the septation between the sphenoid and the postethmoid divider. And widening the sphenoid sinus, and I told you this tumor never ever involve the paranasal sinus mucosa anywhere. See, this is the sphenoid sinus. See the sphenoid mucosa. See the sphenoid mucosa behind?
Yes.
And this is the tumor within the sphenoid sinus. Let me widen the sphenoid more to show you better. See, this is sphenoid sinus. There is some coagulation. First coagulation. Let me apply some coagulation on the surface where it is bleeding. Surface bleeding.
So as you said, Dr. Satish, it looks like there is a good plane between the sphenoid mucosa and the tumor without any invasion as such.
Pardon?
It looks like there is a good plane between the sphenoid sinus and the tumor. You just
yes. So it doesn't invade the mucosa. I told you again and again, this never involves mucosa. Hata. See, whatever tumor which is coming in my exposure, I am coagulating. See more and more exposure?
yes.
The tumor surface. Always use coagulation on the surface to minimize the bleeding during tumor handling. See this? Now this anterior wall of the mucosa, I am widening. Anterior wall of the See this anterior wall, I am going to widen to get the full view of the tumor of the sphenoid sinus. See this? See, I am widening the anterior wall. Widening the anterior wall. See how the tumor is freely occupying the sphenoid sinus. See this? It has gone from here. Can you see the defect in the floor?
Yes. Yeah.
This tumor has gone here and I am widening this defect so that again we can pull it down. Okay?
So that's your bottleneck there, right? So
yes. See, that's the defect in the floor. That's the defect in the floor, which I am removing. Widening this defect. So this tumor again can be pushed back in the sphenoid, in the nasopharynx. See this? I am widening the floor. See this tumor, I can again push back in the nasopharynx now. Can you see very clear?
Yes.
See this tumor, I can push it back down. See the sphenoid sinus inside.
Yes.
Very clear?
Yes, absolutely.
It has gone up from here. I will similarly push it down. So I have widened the axis. And see, this is all periosteum attachment which I am taking care of. See, tumors, periosteal attachments. See, these are the periosteal attachments of the tumor. See how this tumor has gone in the sphenoid sinus. And sphenoid mucosa is never involved. That's the best part. Similarly, we will pull it back. Okay? See this tumor which has risen up in the sphenoid sinus. This is the tumor component. See, this tumor component is bothering us again and again. What I will do now, I will cut it off without any problem. To give additional exposure. See, I'm cutting with a cobbletter. It is like
I see hardly any blood.
cutting the butter. It is like cutting the butter. See, I am cutting the tumor, yet without any issues. See this?
It's quite amazing how little blood there is.
See now the tumor in the sphenoid sinus and the sphenoid sinus mucosa is uninvolved. Can you see all around?
Yes.
Yes.
very
This tumor
clearly.
is bulging from below. From here, I widen the axis from below and similarly I will push it down. I hope it is very clear. So this is the superior exposure of the tumor. Now see in the paranasal sinuses. Now what Dr. Lewis was saying, that attachment towards the midline. Can you see this tumor attached to the septum?
Yes.
Yes.
This is very important, crucial, as Dr. Lewis mentioned, because it can on the opposite side as well. See this? I am cobbleting the periosteal attachment. Cobbleting the periosteal attachment under vision. See very clear? And then I will segregate, completely segregate from this periosteum. That's it. No question of blood supply now coming to the tumor from any other side. The tumor completely segregated off the septum. Can you see very clear now?
Yes.
Yes. Yeah. See the periosteum.
So this tumor is now bulging in the sphenoid and I have adequate access, I have made to pull it down. See this? This access
Yeah,
I
it's
will
very
further
clear.
widen by removing this chunk of bone over here. To widen the access. See now? This chunk of bone I am removing to widen the access. See now? This entire tumor can be pushed down straight without any problem. Can you see the tumor?
Yes.
It has gone up in the
very
sphenoid.
clearly.
The way it has gone up from below, we have widened the axis to pull it down. Debrider. This is to show that how this tumor can easily be pulled down into the into the nasopharynx. See, the sphenoid axis has been widened. See the sphenoid sinus mucosa. this bone in the floor needs to be removed further. The tumor can be pushed down easily. See this?
Mhm.
Now see, there is no obstruction for this tumor to come down. See, this tumor is, I can pull it. It is dying to be out like this. See this?
Yes.
I am not doing that right now. See now the superior, this medial exposure towards the septum. Right. Okay? So I will just leave a gauge piece to keep my field good at this point of time over here.
So,
I
Dr.
hope
Satish,
this,
there's a question about internal carotid artery in a sphenoid.
yeah.
I mean,
So
how
internal
do
carotid
you sort
artery
of
runs
deal
to the
with,
post. Pardon?
how do we deal with this in this situation?
This tumor doesn't invade the mucosa. Artery is beyond that. Not only mucosa, but there is a bone also behind.
Yes.
This artery never goes, this tumor never goes directly to invade the carotid artery from the sphenoid side. It goes cavernous sinus and carotid from the orbital fissure side. I will show you that extension and remove it under vision.
So even if there is a carotid artery dehiscence, the bony dehiscence, there is a mucosal protection, correct?
See now the exposure? The lateral, the superior and the medial exposure. Can you see very clear?
Yes, it's very clear. Very wide.
90%
You
of
surrounded the
time will
tumor
be
nicely.
invested in exposure, exposure and exposure. Now I will expose posteromedially because this tumor is occupying the nasopharynx, going to the opposite side and taking a very important attachment to the nasopharyngeal roof, which can invite the blood supply from the opposite side. See this? From
Mhm.
of the tumor, anterior surface of the tumor here, I will do a posterior septotomy here. See this?
Mhm.
Only this posterior or posterior most septotomy to go to the opposite side. See this? This is posterior septotomy or septectomy, whatever.
Mhm.
To go to the nasopharynx of the opposite side. See? To see the tumor extension to the opposite side and segregate pharyngeal roof attachment, which is an important source of bleeding. Very, very important source of bleeding. And after that, my tumor removal will start. Carefully remove the entire bone. I told you between the various components of the tumor, no intervening bone should be left.
Mhm.
Do you find if it's a revision case that it can often be much more scarred and fibrotic when between the junction of the tumor and the mucosa?
Yeah, see, this tumor doesn't invade the mucosa as such,
Mhm.
except at certain levels I mentioned, where it invades the like septum and turbinate.
Mhm.
See this? The opposite side, inferior turbinate, can you see very clear?
Yes.
Can you see?
Yes.
See, I have gone to the nasopharynx on the opposite side. See this? Opposite Eustachian tube. Can you see?
Yes.
At this point of time, let me use my on the edge of the septum where it bleeds a little bit. contact with the inferior turbinate where it can bleed. See the nasal floor. And here toward the roof. See this can bleed surface. Now, this attachment to the nasopharyngeal roof, this tumor never takes attachment on the adenoid surface. Never. It takes attachment on the periosteum of the nasopharyngeal roof. See this? And here I am truly segregating. I am using now cutting to cut the periosteum to segregate the periosteal vessels from the opposite side. Can you see this?
Yes.
Completely segregated till depth. So no opposite side bleeder can contribute now this tumor to this tumor. Can you see very clear?
Mm-hmm.
Very clear. See this opposite side has been segregated. There should be no doubt about it. Let me remove this gauge piece to show you better. See the opposite section. See the opposite side is segregated very clearly.
Yes. Yeah. Yes.
There should be no doubts at any step.
So on the opposite side, you've come down right on the face of the sphenoid. Is that correct?
Yeah, that is the sphenoid face.
Yes.
And this is the keel below. Can you see this?
Yes, yes.
And see below that the entire periosteal attachment has been sacrificed.
Mm-hmm.
No attachment should be left to acquire the blood supply from the opposite side. See, I am everything coagulating.
Yes.
This is very, very important to ensure that no bleeding should come from the opposite side vessels. See this? This is midline. Now everything done. Now this is the time to plan your tumor removal. See this? You're exposed from all around. I told you my majority of the time is going to go in exposure.
Mm-hmm.
And I told you in tumor removal, my strategy of planned division, I told you in the beginning. I told you we'll divide the tumor at the level of the lateral nasal wall in a planned way, if you remember. Remember?
Yes. Yeah. I think we'll come to that point now. Since you can clearly see that bottleneck.
Yes. एक section नीचे रहो.
How does the coabulator work on a softer tumour such as a schwannoma?
On?
Does the coabulator work well with that as well? Would you use, say you had a trigeminal schwannoma, for example?
Yeah, the approach is same.
Same.
Approach is same, but that is not that
coabulator works well.
Now see, this is the bottleneck. एक section नीचे रखे ऊपर. See, this is the bottleneck. Can you see?
Yes.
Where I earlier entered into the tumor accidentally. Bipolar. Here. Later. See the bottleneck of the tumor in the median. This is lateral component, this is medial component, and medial component the sphenoid. Can you see here?
Mm-hmm.
So we're ready to divide the tumor now, right?
Yes. See now what I am doing. See, I am doing what I am doing. I am connecting this pedicle with the bipolar. Can you see?
Yes.
So before dividing, I am additionally ensuring And I will immediately divide with the cobbler. Then I answer the. See this? Further coagulating this tumor surface so that I can divide with the cobbler. Can you see very clear?
Yes.
Between the medial and the tumor. This is planned division. जल्दी कर यार 5 कर ये no pull up. Now see. Yes. See my cobbler?
Yes.
This is again coagulation. पकड़ना पकड़ इधर कर now I am dividing with the cutting. See, I am dividing at the level just bang on the bone. Why do deep section? I am going bang on the bone. See this?
Yes.
Yes.
Section करना पीछे bone देखा. Yeah, see. See, I am going bang on the bone.
So there's the pterygoid.
Yes, that's the pterygoid process. See the medial part of the tumor created from the part. Can you see?
Yes.
That's the medial part of the tumor. That's the lateral part. Completely segregated. Some oozing here will continue. This is the pterygoid component. See this pterygoid bone component. Now go there, suggestion. See this pterygoid bone component. This tumor is within the bone of the pterygoid. This tumor is within the bone. I just
Yeah, we saw that on the fat suppress MR that
so what I will
the
do.
pterygoid was infiltrated.
What I'll do, I'll just place a Satish on the surface and press with the gauze. Nothing.
So, Dr. Satish, is this the vascularity we were seeing on the fat suppress MR? That the tumor, the possible tumor infiltration within the pterygoid?
Yeah. So this vascularity is from the pterygoid bone. See, tell you there are 3 sources of vascularity. See now, one is from the external carotid system, which is principally the internal maxillary, which you either or take under control like we did, because principally it is from internal maxillary and we took intraoperative control. Number 1. Second source of bleeding when tumor grows further to the skull base is from internal maxillary artery, internal carotid artery, which you cannot mean you like it, you cannot do anything to face it. Like here, from the pterygoid venous plexus, see which we have pressed. This again cannot be embolized. But to face it, I have to control it later on. Why I have pressed with the watch piece. Can you see?
Yes. Yeah.
Now my medial tumor and the lateral tumor are 2 different components. See this? So now I will remove the medial tumor. It is 3 parts. the part which is rising above in the sphenoid. See this? I will pull it down now. See this?
Yes.
It comes like a baby. See, it has come out of the sphenoid because it doesn't take attachment. And we see how much the sphenoid was widened. See now, this is on the
Yes,
anterior
very
face of the
nice.
sphenoid. It is out of the sphenoid so easily. And now, here, it has some periosteal attachment to the sphenoid.
Probably coming to the median area there.
See this? Which
Yeah.
I am going to separate, which I am going to later.
Well, Satish, we're coming close to the median now.
Yeah, we destroyed in the, I will show you. See now how the tumor has been fallen down. See this? The tumor has been brought down and it has a small attachment here in the roof. See this? See this? And
Yes, yeah.
I can remove this.
Wow.
The medial component is out without any issue. See this? Can you see the medial component of the tumor?
Yes, we can.
And what it has given us? It has given us the space to accommodate the lateral component now. Got my point?
Yes, yeah. So we can
That's why
have a much better
this was
access
a
in the view.
strategy to divide it back. Now, for the mucosal ooze, I'll pack for a minute or two. And then we'll start removing the lateral component to various areas. Various difficult looking areas. And believe me, it is a cakewalk now with this kind of exposure and space in the nasal cavity and nasopharynx. It will come out like a cakewalk. In next 10 minutes, we'll be through. See now the medial part of the tumor has been removed. Things are under control. See the visualization. And I hope you are all oriented.
Beautiful. Yes, beautiful. I mean, this is modified Denker's approach. You can see the very large
That's the
maxillary
beauty of the
sinus
Denker's
cavity.
approach.
Yeah.
That's the beauty of
Right
this
from-
approach,
Yeah.
that it gives opportunity to visualize head on everything. Approach head on everything. One girl. See this? So this is for a couple of minutes to make the field good. And now we'll embark on the lateral component. We have seen we have a huge component in the infratemporal fossa. Superiorly, inferiorly, anteriorly, posteriorly, everywhere. And from there only, it is going in the inferior orbital fissure, superior orbital fissure, and then in the cavernous sinus, which we have to pull it in our next couple of minutes. That's it. So our major part of, surgery has been done, which is done with the exposure. See the medial component removal, it didn't take more than 5 minutes.
Yeah. It's very swift. Not
How
much
is the
bleeding as
field?
well.
How do you see the
Field
field
was-
now?
Field was brilliant. I mean, now the bleeding has virtually stopped. Even during the removal, there's hardly any bleeding.
Just a minute or two. I will improve the field and then we'll go with the tumor removal of the lateral part. The biggest tumor is in the lateral component, and you will find this is easiest to remove as compared to the, what it was looking like. Any questions meantime?
I think we're good. I mean, you've explained everything very thoroughly. We've gone as per the strategy, and it has worked very much as planned. So we divided the medial component, lateral component, and anatomy at display is fantastic. Let's see the whole maxillary sinus very widely open, right from the roof of the sinus cavity to the floor. It's very flush with the nasal floor. Then the posterior wall is open. The IMAX have been secured, and now the lateral component of the tumor is there. And Dr. Satish is carrying on with the strategy of surface coagulation. We're using the coagulations. It's a surface coagulation, really, because the blood supply of the tumor essentially is all along the surface. And as Dr. Satish explained, as the tumor grows, the central part of the tumor tends to be a necrosed one, and the periphery is vascular. Yeah.
Now, we go ahead with the tumor removal from the lateral part. And the strategy, I told you, it has gone everywhere. We have to pull it out. So it's a sort of traction and counter traction, which is going to be the strategy. Now see, we catch the part of the tumor and then we'll look next. And then we'll keep advancing our instruments. Yes. See this? Catching the part of the tumor. Can you see?
Yes. Yeah.
This doesn't invade the muscle. It prolapses, goes beyond. It doesn't invade. See the tumor surface. You keep advancing your instrument. See this?
Yes.
This is V2 which I am separating. See, keep advancing your pull to get the tumor. See this?
Yes.
And see, this is my traction and counter traction with the oblator. See, just to show you.
We seem to have lost the video. So while the video is connecting. So what do you think of it, Louis? Sorry, you're muted.
Sorry, I was on mute there, Ashok. I think what's really interesting is the fact that the patient has not had preoperative embolization, but yet with this technique where you do the surface coagulation, you then find the internal maxillary artery, the field is virtually bloodless. And I think that's, the JNA is quite anxiety provoking because of the vascularity. But actually you can see how you can achieve a bloodless field in clean dissection, with this technique.
And this is even without any embolization. So that's really incredible.
That's right.
I think we're seeing all through these 3 days, we're seeing a very common link here. So the surgical procedures, all these master surgeons, although the pathologies are extensive, they can be quite scary into a very difficult areas. But what they have done is broken down into different small mini procedures, to say, like modules, as you said yesterday. And then addressing that individual component, they all come together to become that surgical procedure. So just looking into the details of it, nitty-gritty, and having a strategy in place to deal with that particular part of the surgery. Yeah, so there's a fine example here where we're witnessing how he very carefully analyzed the blood supply, the vascularity of the tumor, and each part he had a different strategy.
Hello. Hello.
So we're back.
Hello, Dr. Okai. Hello.
Hello.
Are you with me?
Yeah, yes, we lost a picture for a minute or so, but we're back now.
We can somehow disconnected, but see now, the entire tumor being pulled, all the lobulation of the tumors are being pulled. Can you see very carefully?
Yes.
Very clear?
Yes.
See, the traction and counter traction is the key. Yeah, hold, advance. See this? The hold is and advanced. And more deeper tumor being pulled off. See this?
Yes.
See how
Wow,
big
what a
tumor
discovery.
it
Wow,
is.
that's amazing.
Wow.
See how big this tumor is. Yeah. I told you the end will find some bleeding from the middle meningeal behind. See this?
Yes.
Yes.
See this coming from behind. See our vessels which we have clipped. And see this bleeding. This is mainly coming from behind. Give me a gauge, please. See this bleeding?
Yes.
Because there was a vessel coming from behind. See very clear? And some more vessel which I am coagulating here.
Yeah, you can see the vessel very clearly. Beautiful.
See the entire infratemporal fossa is empty now of the tumor. Oh, sorry.
You can see how the internal maxillary artery has gone almost back into place, having been stretched around the tumour.
This is the vessel which is coming from above. See this? See, there's a vessel which is coming from above, and we'll tackle it later after the tumor removal. Meantime, we'll just put a small piece of Surgicel over it and pack. See this? Can you see that beyond the tumor it is? Hello?
Hello, yes. Yeah. Maybe
This is beyond the tumor. The entire tumor has been pulled medially. See this? We'll just pack it. This vessel I told you on the scan, we have to face it. And we'll control in no time without any issues. See this? Later on, we'll most likely clip it or coagulate it. Not now. Right now, our goal is to remove the tumor first. See this? All lateral tumor has come in the medial part. See this? See this?
Yes.
See? See this? All tumor everywhere. See everywhere?
Yes, sir.
Yes.
Now, see this. This tumor is going in the fissure. Can you see this? This is the last component which is going toward the cavernous sinus here. See this? And I will gently pull it off. And you will see the gush of venous bleeding after that. That will be healthy bleeding. Now, see now how gently you have to pull it off. See this component close up. Can you see?
Yes.
Look at
so that's the section that was going back to.
Look at my pull. Look at my pull.
Wow.
Keep advancing. Gentle pull. It will not break. This is from the supraorbital fissure, and this last component is coming from the cavernous sinus. See this?
Yeah.
Yes. See this last component coming out. This last component coming out of cavernous sinus. This one. What's up, Dedu? See this last component which is coming out of the I'll remove this part of the bone. See this component? Keep an eye on it.
Yes.
Keep an eye on it. पकड़ने वाली देना एक। Flux दे दे। See this last component which is coming out.
Yes.
This is true cavernous sinus component. And see the venous bleeding afterwards. See, it has come out one piece
Wow.
One piece. Wow.
from the cavernous sinus, and see this cavernous sinus from inside. See the venous bleeding.
Yeah.
Yeah.
Heart section. See the venous bleed. Can you see?
Yes.
Yes.
Yeah.
This is healthy bleed. I am not keen to pack it tightly here. See, the entire tumor is out within the nasal cavity. And now I will push it, since it is too big. No. Since it is too big, this should be pushed through the oropharynx. And there is a pack. First, let's move the pack from behind. This pack. For that, we can push our tumor behind now. See this? Huge tumor. Huge tumor going down. Wait. See this? Yeah. See the V2 there up. Separated. I am not packing the cavernous bleeding so far. All packs removed. Wash. Just let me show you. All packs removed. I want this little bit of venous bleeding to come. Ensure that no tumor is left behind. See the cavernous sinus from inside. Can you see the cavernous sinus?
Yes. Yes. So venous ooze.
This is cavernous sinus. This is sphenoid sinus. And see the pulsations of the carotid artery. See the carotid pulsations.
Yes.
Can you?
Yes. 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 We can see it very clearly.
So now I will
planning to
leave
use
a
any flow
small
seal here?
Surgicel. Give me a small
Surgicel.
Surgicel. See entire tumor out.
That's
Lateral
incredible.
component.
Yes,
See V2 which is running all the way in the roof. Can you see this?
Yes. Yeah.
Yes.
This is the cavernous component. And I will place some Surgicel into it without pressure.
That's amazing. And all done with the medial wall of the cavernous sinus remaining
Without
intact.
pressure. See, I'm not using any pressure
Yeah.
at all. There are lots of nerve running through the cavernous sinus and you are not supposed to pack tightly. Okay? I'm just leaving the Surgicel and putting a pack over it so it doesn't come out. See this? With no pressure at all. Shoulder. See this? Let some blood come out, doesn't matter. It will stop automatically. See this? And now this tumor which is released. See, it is completely released out. See the tumor which is completely released. See the tumor completely free. Hello.
Yes. Yeah. Yes. We can see that. Yep. All along the floor.
Nasal cavity, sphenoid sinus, suction in this sphenoid sinus, the pack towards the cavernous sinus and pack towards the infratemporal fossa. All clear?
Yes. Yeah.
Yes.
To see all the
Yes.
landmarks in.
We will push this, tumor, push this tumor in the oral cavity. and remove from there. Now, see this? See this? This has
Yeah.
been
Yes.
pushed. A pack in the nose meantime for a while. A gentle pack. Keep the feel good. See the nasal pack? No bleeding otherwise. We have pushed the tumor down and then we'll remove the tumor per oral. So lateral component didn't take more than 10 minutes, I told you. Look now. Suction cup. See, this is the tumor which is coming out of the oral cavity. Can you see?
Yes.
Yes.
Yeah.
Various components of the
Yes,
tumor.
yeah.
Various components. And this was the cavernous component. This was the infratemporal fossa. See this all component. All components of the tumor. And this was earlier the medial part of the tumor. This tumor was like that. So we divided it here at the medial part. See this?
Yes.
This was separated earlier. This was going up in the cavernous. This was going in the infratemporal fossa. The entire tumor. Can you see very clear?
Yes.
Yes.
Now, let's check the pterygoids. Let's check thing. Let's check the vessel. See now everything under control.
Yeah, it's amazing. There's hardly any bleeding, isn't it?
It is the axis
Very
which
minimal.
matters. It is the axis which matters. ये देखो मेरा, ये देखो. This is the part where we cell. Can you see?
Yes.
Yeah. This is pterygoid venous oozing outside, which starts with the packing. You don't need to really do anything much. एक वो रखना, forceps or clip. Now this was the vessel which was coming from behind and showed you an MRI as well, which was supposed to avert from tumor removal. See, these are our vessels which we clipped earlier. Can you see? Yeah, and see we packed and everything under control. Give me cobbletter. So I want to coblet that vessel area. See, this is all infratemporal fossa. See how the infratemporal fossa bleeding control with the coagulation.
Yes.
Now this is median canal, which I am going to drill off later. See this one. This is median canal. This is
That's a common
V2
site of
going up in the
resident.
foramen rotundum. Hello.
Yes. Yeah.
This is V2 going in the foramen rotundum. See above. This is the eye. This is the serpentine course of the V2 in the roof. See this?
Yeah,
Yes.
you traced it all along.
This is cavernous sinus. This is here going to be the foramen rotundum region. This is all pterygoid process which was having the tumor. See, this tumor was here, which ultimately we have to ensure a microscopic clearance. Now, give me some Surgicel. For the infratemporal fossa now. See, entire infratemporal fossa very clear.
Yes. Yeah. Lovely.
Now I will pack because this muscle surface can ooze. So Surgicel one more.
So median canal tends to be one of the common site of residual disease, isn't it? So
Very
planning
good.
to drill around the canal.
See this? Just leave. Now, this bone is the notorious bone, which is often invaded by the tumor. Very good. Now see, this is the region of the median canal. Can you see the median now?
Yes.
Yes.
See how it is destroyed. Can you see?
Mhm.
This bone is a cancellous bone and often invaded by the tumor. First, let's work that. The nerve transected, whatever soft tissue there, and we have to ensure this cancellous bone is tumor free. So I will use my special drill for that. Again, high speed diamond drill. Super. Canal with suction. Wash करके suction करो. See how the normal bone bringing out. Can you see?
Yes.
All this cancellous bone has to be now. See this entire pterygoid process all around the V2 and median. So-called recurrence. खतरो. Section रख. Wash. Give me a wash. Just wash. Dharma. और वॉश रखना मैं लोगों वॉश 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 मन पड़ा है आगे से मन पड़ा आगे से फिर मैं वॉश हेलो
Hello?
this is fine tuning now to ensure that no abnormal bone is left behind.
Minimizing the
Finish.
chances of recurrence, really.
Yes. Just finishing. See the edges of the cavernous sinus opening. See the V2. Now see each and every area close up. दूर रखने को बहुत बड़ा है. See now this is cavernous sinus region with Sergi cell. Nothing. See the there. The V2 बीमारी है तुम्हारी बोले तो हले बोले पतला ले यार yeah again see the close up now see the pterygoid bone can you see
Yes. Yeah.
the cancellous bone can you see very clearly this is V2 where the foramen rotundum is where this infraorbital nerve is going in can you see this very clear
Yes.
see the pterygoid below pterygoid has been
Very good.
drilled off and flushed. See, this is thin bone is left behind. See, pterygoid. This is median canal where the median nerve sacrificed, cut and flushed. Everywhere there is no tumor. Can you see now?
Yes. Yeah. Agree.
This is the
This was nicely
advantage of
clear.
endoscopy. This is the advantage
Very
of
clear.
endoscopy. You can to find crevices, canal, foramens. This is the biggest advantage of endoscopy, which is called open surgery. It is not that the scar which matters. The entire cancellous bone has to be thoroughly cleaned off. Now I can say that no tumor. See this? See, look at the pterygoid.
Yeah.
No
Very
tumor
handy
has
now.
been left behind. Can you see?
Yeah. I think that's the
That's
key
the
to minimize the
pterygoid.
recurrence.
That's the pterygoid. That's the palatovaginal canal containing the pharyngeal nerve. See that? Wait. T2 and this is the cavernous sinus. This is sphenoid sinus. So all this area, this is infratemporal fossa, see your internal maxillary clip there. And this is by V2. See this? This is infratemporal fossa. This is your nasopharynx. See your चलिए नहीं रहा बंद है. See your see both the Eustachian and tube orifices. This is adenoid surface. It never takes attachment on the adenoid surface. See this? Can you see? Very clear?
Yes. Yes.
Yes.
Yeah.
Just so now we'll finally close with some Surgicel, some nasal pack for a day or two. So that's all about the pack. That's all about the endoscopic, excision of juvenile nasopharyngeal angiofibroma with the all named extensions. इधर ले आओ, कुछ cut कर दो. Any questions, any suggestions so far?
No, that was wonderful. It's a great technique, removing the whole tumor, minimal bleeding. That was quite astonishing, wasn't it? With that size of the tumor, with that vascularity, without any embolization, very minimal bleeding. So
Volume बढ़ाओ ना इसका कहाँ है?
brilliant.
I need a picture.
The technique used makes it look straightforward and simple, but it's anything but.
Yeah, absolutely. You need to know about your anatomy, where exactly you are, where the vessels are located, and individual vascularity of that particular area, and having a strategy to deal with it. We saw the use of coblation, use of Lager clips, use of bipolar, and dissection. Often use the coblation wand as a dissector and very selective coblation at the same time.
I think as well, having the confidence to just gently pull the tumour that was in the cavernous sinus.
Yep.
You know, just patience and just that sort of gentle pressure to bring it out. And it's quite amazing seeing it coming out all in one piece, isn't it, on block?
Correct. Apart from this central division, the rest everything will kind of fall in place.
Yes.
See, with this kind of situation, there is always a question regarding indications for open approach. See, in this case, there was no indication for open approach. The reason was imaging guided us where exactly the tumor is extending to, what are the crucial areas where the tumor is going to, whether there is any intracranial major vessels supplying to the tumor which can create problem, which makes you think for an open approach, which was not in this given case. So it is not the, extension, it is not the size of the tumor which matters for the indication. Indications now in this era are well defined, and due to progress in the endoscopic approach, more understanding of the anatomy with equipments, coblation, cameras, high-speed drill, it has more and more become easier to approach the tumor endoscopically with distinct advantage. The way we defined all the canals and drilled away the pterygoid is not possible so easily in the open approach. In the open approach, you remove the tumor in one go and pack because of the bleeding, and you don't have any opportunity to inspect into those critical areas. So it's not about the, the fear of bleeding, makes the surgeons to choose the open approach. So you have to apply the strategy to control bleeding. Coblation was one of them. Catching the vessel prior to tumor removal was another. And using Surgicel packs, adrenaline packs, anesthesia, all those things ultimately contribute to overall reduced bleeding without even embolization.
Yes.
Sometimes, I don't know about the UK and US, but in our country, and I think it's everywhere, the cost of embolization sometimes exceeds the cost of surgery. It's on disadvantages. No embolization is safe. Though embolization techniques have improved, the experience of the intervention radiologists matter. The cost is the biggest factor. And, in such tumors, there are frequently, you will find on DSA, dangerous anastomosis between external and internal carotid system, which an intervention radiologist by experience can avoid your material extending into internal system. Otherwise, it can be very, very difficult. So, looking at all the aspects in the present scenario, in the primary setting, over 98% of the JNAs can be or extirpated better by the endoscopic approach with distinct advantage. Forget about the scar, which is the least of the advantage. I would enumerate. The advantages are obvious, we discussed throughout. And this is why this is the preferred approach. And we have a large series now, over 400 something cases with major JNAs. We have been able to remove without embolization and majority without even transfusion. So this is how you have to, plan our strategy for JNA. Any questions, Dr. Ukade? Any more?
This case is a fine example of that, what we witnessed today. I mean, if you can manage the surgery with such a minimal bleeding, it's probably bleeding very comparable to a tonsillectomy bleeding. Not even that, I would say. So if you can manage it without embolization, then definitely why take all the risk of embolization? It avoids altogether. So there's a distinct advantage. And as me and Luis were discussing when there was a break, that breaking down the surgery, complex surgery, into different components, and then having a assigned strategy to that component, that makes the surgery really safe and possible, even though at the outset it looks very huge tumor, complex surgery. So you have demonstrated that very, very nicely. And thorough study of the imaging, again, what you have shown this morning, that underlines how surgeons should be approaching the imaging studies and looking at the pathology and the anatomy very carefully. And that goes a long way, spending that time in planning your surgical strategies.
See, the science of endoscopic surgery is growing like anything. I think probably the fastest growing science in the medical specialty, entire medical science. And now, with the better understanding of anatomy, equipments and all those, boundaries are unlimited. Earlier, I remember my training with Dr. Dharamveer Sethi from Singapore, who was the, magician for endoscopic sinus surgery, but still is. And amazing the way he displayed the anatomy and demonstrated and taught. It was amazing. Then the science grown further. Now, in the present context, I would say boundaries unlimited. Earlier, it was in 70s when Messerklinder and Stamberger did the research work. It was indicated or, developed for treatment of inflammatory disease of the paranasal sinuses with minimal work.
Correct.
Just open up the sinuses for ventilation and drainage, that's it. And now see how the application or the indications have expanded. See now, not only for the inflammatory, for tumor, not only for paranasal sinuses, but even beyond. Surrounding areas, infratemporal, parapharyngeal, pterygopalatine, orbit, everywhere you can, introduce endoscope and remove under vision. Then, not only for the skull base, even for the pure intracranial lesions, this is the preferred approach for distinct advantages. And I believe this science is going to grow further with the advancement in the technology, now with the lasers, now with the, this robotic surgery, now with the cobbler being incorporated with the other tools to go high up skull base, intracranial, and lasers being incorporated, so many things, the way it has a dynamic image guided system. So this is going to go next level in the coming times. So thank you very much.
So in aviation, the hierarchy is aviate, navigate, communicate. So first of all, you have to fly the aircraft. Only when you've got that safely done, safely achieved, you can start to navigate. And only when the navigation's taken care of do you then communicate with air traffic control. So to an extent, if you're flying, you're either navigating or you're lost. So what are the threats from being lost? Well, you might have to land at the wrong airfield or run out of fuel before you can find somewhere to land. You might infringe airspace, possibly causing a diplomatic incident. You might infringe what we call a NOTAM, which is a notice to airmen. which could be in the UK, it could be a member of the royal family flying from A to B in a helicopter. All of these things will get you into varying degrees of trouble, and that's what we're trying to avoid. So there are several layers, if you will, of navigation. The first one, if I'm flying along, let's say I'm very familiar with my local airfield and I'm just going out for a Sunday jaunt, then I'll just be navigating visually. And I'll know all the features around that airfield, and that should be a pretty easy task. If I'm then going further afield, then I might start to use a map and stopwatch. So on my map, which has got all the airspace on it and lots of features that I can see visually, I'll draw a straight line with a ruler, and I'll work out how long that leg of navigation is and what heading I need to be on to fly that leg accurately. So we've gone from visual navigation to then map and stopwatch navigation. And after that, if I've got systems in my aircraft, I can start to use those. So as a fighter pilot in our aircraft, we had inertial navigation systems. So a bunch of accelerometers and G meters, and they work out the change from one moment to the next. And they're very resilient to maneuver, which is good if you're in a fighter aircraft. So the airplane knows where I am in one moment, and then it looks at how much acceleration I've put it under, and therefore it knows where it is subsequently. But over time, those systems drift. So over about an hour, I might lose about a mile of accuracy with that system. So every once in a while, they need updating, either by flying over a feature on the ground, or by GPS, or by radio beacons. So we had visual, we had map and stopwatch, and that was talking about my inertial system in my aircraft. And then if I'm flying along in cloud, if I'm an airline pilot, I've got inertial systems, but I'm also using radio beacons to navigate with. And they're pretty accurate. And generally airliners fly, or certainly they used to, less so these days, they used to fly from one radio beacon to another. And that's navigation in a nutshell, really. And these days, a lot of those systems are combined. So as I hinted at, the inertial navigation system will be updated by something like GPS. And GPS is very accurate, but it's not very resilient to maneuver. So combining those two, where you've got the inertial system, which puts up with the maneuvering, and you've got the GPS, which is very accurate over time, gives you a really robust system. So hopefully not too technical there, but the aim was to provide an overview of the various navigation systems.
Well, it's interesting. I sort of started training when navigation was being introduced and more accepted as routine, but we didn't use it in every case. It was considered quite fancy and high tech. And really what we've always used is key landmarks as a way to know where you are. So before you even consider operating, you'll do some form of scan, usually a CT scan. And a CT gives you better landmarks from bony anatomy, which is more reliable in surgery, because soft tissue anatomy can change. You can have swelling and shrinkage and polyps and infections and things, but the bony anatomy doesn't tend to change over time unless there's tumours, etc. So we usually have a CT scan, and before you operate, you'll go over that scan and identify those key landmarks, but also identify unusual anatomy or some changes in the anatomy that are unique to that patient. There's some key things we want to know: where are the blood vessels that supply the eye that can hang down in the nasal cavity so we don't injure those, because that can cause blindness if not addressed. We also want to know where the base of the skull is so we don't breach that if we're not intending to. We want to know where the eyes are and what the shape of that patient's orbits is, if they're a bit square or rounded, so we don't penetrate into their eye or injure any of their eye muscles. We also want to know where their optic nerve is, among other things, as well as their carotid arteries. So there's a few key things we look at as a routine, and we have a mnemonic called CLOSE, C-L-O-S-E, which looks at those key anatomic features in every patient, because they're unique in every patient. And then when you've looked at that, you've obviously examined the patient looking for other things like septal deviations or turbinates or big polyps. What we then rely on is, with the endoscope, we're relying on that anatomy. And as we proceed through the surgery, we're sort of ticking off those things in your head. Okay, I've identified that artery and I've left that alone. I've now worked out where the orbit is and I've cleaned that off. I've left that alone. I've now moved through to this particular sinus where I can now find the skull base or the optic nerve, etc. So really what we used before was anatomic landmarks and scans. Now, in dire situations where you really weren't sure, I have known of people to leave a metallic object somewhere, a CT or an X-ray, to confirm that that's where they thought they were, but that's pretty unusual. So we don't have as many fail-safes as they do in aviation. We really rely on anatomic knowledge and anatomic features as landmarks if we don't have navigation.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there, and we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis, because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use that a lot. And these are the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, especially in patients with severe polyps and sample-striate. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.